Hello, everyone. Welcome to the 7th meeting of the COVID-19 Health Equity Task Force. I am Min Wendt, designated federal officer for the task force, covering from Captain Samuel Wu, who's on deployment. The focus of today's meeting is on future pandemic preparedness, mitigation, and resilience needed to ensure equitable response and recovery in communities of color and other underserved populations. In today's meeting, we will hear from the task force members deliberating on a final set of refined recommendations. As a reminder, this meeting is being live streamed and recorded and will be available for viewing at a later time. All material presented in this meeting will be available on the task force website at minorityhealth.hhs.gov/HETF, that stands for Health Equity Task Force. We are providing American Sign Language interpretation for those with hearing impairment. Closed captioning for this event is available at both the HHS live streaming channel and the Office of Minority Health YouTube channel. Members of the public have been invited to provide comments as stated in the meeting notice published in the Federal Register. Written comments will be accepted up to 7 days after the meeting. Please send comments to COVID-19 HETF@hhs.gov. With that, I will turn it over to Dr. Marcella Nunez-Smith, Chair of the Task Force. Madam Chair.
Great, thank you so much, Dr. Wendt. Good day, everybody. Let me just add my welcome, everyone, to the 7th public-facing meeting of the U.S. COVID-19 Health Equity Task Force. And happy Hispanic Heritage Month. A quick reminder of our charge. President Biden charged this task force to provide recommendations for mitigating health inequities caused or exacerbated by the COVID-19 pandemic, and to prevent such inequities in the future. Our prior public-facing meetings have focused on several topics, including the data necessary to drive an equitable response and recovery, equity in vaccination access and building vaccine confidence, behavioral health, recognizing the importance of mental health in this work, xenophobia and discrimination, long COVID, equitable access to PPE testing and therapies, as well as future pandemic preparedness, all centered in equity. Each month, the task force has voted on interim recommendations specific to each one of those key areas. And today, we meet to deliberate on this entire body of work and to vote on the refined recommendations in anticipation of the COVID-19 Health Equity Task Force final report. We know the coronavirus pandemic affects all Americans, but not equally. And COVID-19 continues to have a disproportionate impact on communities of color and other underserved populations across the US. While health inequities did not begin with the COVID-19 pandemic, COVID-19 triggered a confluence of physical health, behavioral health, economic, and educational crises that land squarely on high-risk and hard-hit communities. So as we hold our collective work as a task force, we are mindful ever of the broad lens that is needed to center equity across the most affected groups: people with disabilities, those who are justice involved, older Americans, our rural neighbors, mixed status families, queer people, people of color, indigenous and native people, ANHPI communities, those on the margins of the economy, and others. And of course, the compounded challenges often found at the intersections of these very identities. We are dealing with a legacy of discriminatory and inequitable policies that have limited opportunity for positive health outcome over generations. And these structural inequities were exacerbated during the pandemic by shortfalls in data collection and reporting, and that crippled our ability to meet the moment and respond equitably in real time. And to make equity actionable, we must establish a data ecosystem that promotes equity-driven decision-making. Affected communities are expert in what is needed to advance health equity. And as such, we must invest in community-led solutions to identify and implement programs and processes that elevate this expertise. And to further advance equity, we need a guiding framework, one that includes metrics, health equity impact statements, processes that government entities can use to hold themselves and external grantees and vendors accountable to health equity. The pandemic gives us this opportunity, it's unique, to disrupt patterns of harm, to offer course correction, and intervene to improve inequitable systems and practices. This task force, chartered in response to the calamities of the COVID-19 pandemic, acknowledges these challenges as a place to build, a call to action, a demonstration of why intentionality, intersectionality, and justice must lay the foundation to address health inequities in the United States. When it comes to COVID-19, we know communities of color, other underserved populations face increased exposure and risk for many reasons. In Black and Latino communities, for example, people are more likely to live in more crowded households, multi-generational homes, to hold essential occupations with higher risk of exposure to SARS-CoV-2. For some people with disabilities and serious illnesses, as well as those living and working in congregate settings, social distancing measures often is difficult and pose challenge. And we cannot measure the impact, the effects of COVID-19 without directly addressing and acknowledging the deep roots of environmental injustice in our country. All these living and working circumstances accelerated transmission and exacerbated poor health outcomes for communities that have been consistently left out and left behind. What we're dealing with now is much more than a health emergency. It is a convergence of crises. 15 million people lost jobs within the first 3 quarters of 2020, most of whom women and immigrants were left unsupported by long underfunded social services. Housing insecurity, threat of rental eviction soon followed job loss. Americans losing their jobs lost employer-sponsored health insurance just when they needed it the most, not only for COVID-19 care, but for pandemic-related anxiety, substance abuse, depression, preventive care, so much more. The financial strain of economic insecurity intensified the existing behavioral health crisis in the US. People could not access or pay for the behavioral health services that were desperately needed. COVID-19 also exposed fundamental flaws in our public health infrastructure, in our data systems. That data, that was unable to provide a clear picture of what was happening in high-risk communities, rendering so many invisible and policymakers ill-equipped to direct resources to the hardest hit groups. Our outdated public health and data infrastructure initially fell very short on informing an equitable and real-time pandemic response. And all of this took place against a backdrop of interpersonal and systemic racism. Over this past year plus, we have been heartbroken and outraged at the increase in hate crimes we have witnessed in businesses, on the streets, even in our schools. Injustices with generational consequence, deeply embedded in our society, shape the lives and communities of far too many of us. So we must continue to dismantle the network of structural barriers to stop inequities at the root and mitigate against the pandemic's far-reaching efforts. Right now, today, with this work, we have a once-in-a-generation opportunity for transformational change. And we must acknowledge that advancing health equity will take multi-sectoral commitment and collaboration. The inequities highlighted and experienced during the past 18 months puts the onus on the government and also on the private sector, on community leadership, on philanthropy, together to achieve health justice. This is the work. to disrupt the predictable pattern of who is harmed first and harmed worse. That intentionality, that collaboration, that frequent review and course correction, that's what's going to be required to achieve these goals. This all of society effort is well underway, especially when it comes to the national vaccine campaign. According to the most recent Kaiser Family Foundation data, similar shares of adults now report being vaccinated against all racial ethnic groups. In a report published last week, the CDC's National Immunization Survey of 19,000 adults by phone found that 73% of Black adults, 76% of white adults, and 78% of Hispanic adults have now been vaccinated. And 3 weeks ago, the Pew Research Center surveyed over 10,000 adults online and found 70% of Black adults, 72% of white adults, and 76% of Hispanic adults had received at least one dose of the vaccine. So this increase in vaccination rate, vaccination uptake, and the decrease in vaccination inequity, that would not have been possible without collaboration, without intentionality at every single level of society. All the employers who offered paid time off and childcare to their employees, public transportation, rideshare companies, providing free rides to vaccination sites, healthcare workers who worked with local media sharing the facts, creatives using their platforms to advance critical public health initiatives, and of course, the many family members and friends who made vaccination a family and community affair. And all that said, we know the work is still not done. The gaps remain in vaccine uptake. We continue to see, sadly, hospitalizations and deaths from COVID-19 that are preventable. And we need to push to keep our children safe, including vaccinating them once eligible. So the challenges, yes, are significant, but their correction is vital to the health of our nation. And we are on our way. We can see the path forward. We need stamina and continued creativity, continued collaboration, and commitment to get it done. Vice President Harris provided a blueprint for the U.S. COVID-19 Health Equity Task Force. Her legislation, introduced when she was a senator, closely informed our work. And on January 21st, in this year, President Biden issued Executive Order 13995 to formally establish this COVID-19 Health Equity Task Force. And over these past 6 months, the COVID-19 Health Equity Task Force generated more than 300 interim recommendations. And the Biden-Harris administration has already taken steps that address approximately 57 of these recommendations through a host of executive orders, memoranda, and agency-wide initiatives aimed at ensuring an equitable response to this pandemic. That's 57% of the task force recommendations already implemented or in progress. 57%. A quick reminder how we've done our work, right? The work has been organized across 4 subcommittees: communications and collaborations, data analytics and research, healthcare access and quality, and structural drivers and xenophobia, in addition to 1 work group focused on implementation. And each month, the committees reviewed relevant literature, public comment, and federal agency data to understand the landscape of problems and solutions at the federal level, the state, the local, tribal, territorial levels. They heard from leading experts across the private and public sector with relative perspectives on the monthly topic, met many times weekly to discuss the research, to develop draft recommendations aligned to problem statements, and then briefed and voted on interim recommendations in all task force monthly public meetings. Again, today, the task force will be presenting, discussing, and voting on a final slate of recommendations. We will also consider a slate of proposed outcomes and suggested top priorities for implementation. The task force executive director will provide further details on how the task force synthesized, strengthened, and focused recommendations to develop this final slate. The refined recommendations will next be synthesized into the task force final report and then delivered to the White House COVID-19 response coordinator. The COVID-19 Health Equity Task Force has worked tirelessly to present a vision for change that will help improve equity today and for tomorrow's. Systemic problems require systemic solutions and sustained efforts, and the pandemic is not yet over. These are lessons and actions for now and for moving forward. And we continue to hold hope for a new and better normal. So before I turn things back over to Dr. Wint, I want to thank the task force members for their tremendous commitment to this work, and to the chairs of the task force subcommittees and the implementation work group. Thank you for your leadership, your passion, your vision. A special thanks to all of the ex officios representing agencies and departments across the US government. I also want to extend deep appreciation to the CDC Foundation and federal staff team for all of their support. And to the over 100 subject matter experts and many guest speakers over the past 6 months, thank you for your insight, your expertise, and for your time. I am forever so grateful. With that, I will pause and turn it back over to you for the roll call, Dr. Wint. Thank you.
Thank you, Madam Chair. So task force members, when I call your name, you may respond with present. Ms. Myra Alvarez.
Present.
Dr. Sarah Bleish.
Present.
Dr. Jessica Kadishon.
Present.
Dr. Richard Cho.
Present.
Dr. British Gandhi. Ms. Jamila Gleason.
Present.
Dr. James Hildred.
Present.
Mr. Andrew Imperato.
Present.
Mr. Victor Joseph.
Present.
Ms. Jolinda Johnson.
Present.
Dr. Janae Condon.
Present.
Dr. Rachel Levine.
Present.
Dr. Octavio Martinez.
Present.
Dr. Marcela Nunez Smith.
Present.
Ms. Shannon Pazur.
Present.
Dr. Tim Putnam.
Present.
Mr. Vincent Toranzo.
Present.
Ms. Mary Turner.
Present.
Dr. Homer Ventures.
Present.
Mr. Bobby Watts.
Present.
Ms. Hye-young Yoon.
Present.
Just one more time, Dr. British Gandhi. All right. Madam Chair, we have a quorum for the meeting.
Thank you very much, Dr. Wint. Right, I want to turn things over right now to our Executive Director, Dr. Okafor, to walk us through a little bit more detail regarding the process of refinement of the recommendations that I alluded to in my opening remarks. Do you want to just take a minute and share Dr. Okafor's brief bio with you? I think it's very fitting to provide a little bit more information about Dr. Okafor has been serving as Executive Director of this task force since February, and we are also appreciative of her leadership as well. Before her detail to the task force, Dr. Okafor served as a Senior Policy Advisor in the immediate office of the Assistant Secretary of the Administration for Children and Families within the Department of Health and Human Services, and previously served as the regional administration for ACF in Region 3. And so prior to joining the federal government 2 years ago, Dr. Okafor served as the City of New Haven's Community Services Administrator, a deputy mayor position overseeing health and human services agencies in the city, where she led the transformation across many sectors: education, housing, health, economic and community development through robust public-private partnerships. Dr. Okafor, as you can get a sense, has a long and distinguished career in state government, having held key leadership positions in both Georgia and Connecticut departments of public health. Her academic credentials include serving as the Director of Behavioral Health at the Satcher Health Leadership Institute at the Morehouse School of Medicine, and as faculty at Yale University, where she taught population health, health equity, and health policy and leadership. So very, very grateful to have all of that expertise and your passion and your commitment and your dedication, Dr. Okafor, with the work. I'll turn it over to you, please. Thank you in advance for providing more detail regarding our processes.
Thank you, Madam Chair. As I mentioned, it's been really a privilege to work with the team. Madam Chair, before I get into the details, I just want to thank you for your excellent leadership of this task force. You've already listed some of the work and accomplishments to date. But I also want the public and our viewers to know that the work of this task force is extraordinary because the members are called to perform a duty that normally take at a minimum 2.5 years to do. And they did it in 7 months, as you mentioned, with excellence. So I have to really pause and give credit to the members of the task force and of course your leadership. As we think about this work, Jamie, could you move to the next slide, please? Thank you. So we are going to move, and the next slide. We're going to basically move into why this work is important in terms of what is the basis for this work? Why are we where we are in this work? And I think it's important for us to really think about what Madam Chair has already presented, and that is the President issued an executive order, 13995, to implement the goals national strategy for this COVID-19 response and pandemic preparedness. From this executive order, the task force members were charged to really study the factors that worsen inequities during the COVID-19 pandemic, as well as propose recommendations on how the nation can equitably respond, recover from this pandemic, and how to prevent such inequities in the future. So if you really think about, you're still pondering, how did the task force members get this job done in 7 months when it typically takes 2.5 years to 3 years, and in some cases 5 years to get it done? With that, I'll move to the methods and the refinement, which is the purpose of the work. Under the methods and refinement, I wanted to share that the work, in order for them to get it done, it was really provided in 3 phases, as you will see from the journey slide that Jamie will show. This work that was actually designed to take place in 3 phases started in January with phase 1. And this phase 1 led to the appointment of Madam Chair and 12 members from the public that the president appointed based on their lived experiences as well as their expertise. And they were called to really bring the voices of the population that were specified in the executive order as this task force performed their duty. The charter that I mentioned that undergirds the work of this task force also included the representation from 8 ex officio members. These are senior level executive members of the federal departments that worked with the public members, the 12 members, so that they will be able to look at the best way to address these issues facing the United States during the pandemic. In addition, there were 2 work or expectations of this task force, and that include for the task force to address the presidential memorandum condemning the racism and xenophobia, as well as combating the intolerance against our Asian Americans and Pacific Islanders in the United States. There was also the second additional work placed on the table for this task force, and that is the work that addresses the data shortfalls, which we identify in section 1 of another executive order. But this task force was also asked to address that and ensure a data-driven response to COVID-19 for the future pandemic so that we do not have similar experience. This actually wraps up the phase 1. And then we moved to phase 2 of the work that this task force did. When I said that they did extraordinary work, I think now the viewers will begin to have a feel of what they did. As of February, when this task force was stood up and we started the work, Madam Chair organized the task force into 4 subcommittees. For those that have been following the task force since February, you will know that the 4 subcommittees were the communications and collaborations, the data analytics and research subcommittee, the healthcare access and quality subcommittee, and the structural drivers and xenophobia subcommittee. All these subcommittees were actually crafted based on the priority issues that are highlighted in the National Strategy, Executive Order, as well as the Charter. And they did their work effectively by focusing every month on different topic area, which Madam Chair has identified, and I will not go through them again. But I wanted the viewers to understand that during this second phase, which started from February to July, that every month the task force actually met, reviewed literature. They heard from leading experts, including those with lived experiences, and they all drew from their own experiences, their expertise, and came up with potential solutions for their topic area. When I said that they met, I just wanted to emphasize that their meeting was really real working session. It's not like sitting down and talking, because they all had their homeworks. They had tons of materials to read and they came prepared. And that was how they generated over the 300 interim recommendations that Madam Chair mentioned. In addition, they had over 200 working sessions done within this month, and they met with over 100 subject matter experts. And this actually led us to phase 3. Under the phase 3, the task force members were able to, basically had a deep dive into those 300 interim recommendations, and they began to work on refining them and reprioritizing them. Out of those 300 recommendations, as Madam Chair said, this administration had already begun to work and implement at least 57% of their suggested solutions. That tells us that 170 of these recommendations, actions had already begun on them. That is tremendous work and impact already. And looking at now for the refinement phase, which is their 3rd phase, they were able to still go deeper and look at each of these recommendations. To what extent did each of them address impact, which is one of the criteria they use, and under impact, systemic racism. They looked at which ones actually improved quality of life, which ones improved resiliency of individuals that are impacted by this pandemic, communities that are impacted by this pandemic. They also focused on evidence as a criteria. Under evidence, they looked at to what extent each of their recommendations have evidence-based research, as well as promising practices, because we know that the communities were generating promising practices to address the inequities. And the task force members were tracking all this critical information. And they also looked at which of their recommendations have equity-centered policy to back it up. And after they've advanced those recommendations that met these requirements, then they further went into feasibility. Which of them are implementable? Which of these recommendations have available funds, existing programs, capacity, policy that are viable, and the policy that could be strategic, not just right now, but for future pandemic, as well as addressing future inequities that we face. and which ones are measurable with great accountability metrics. After doing this extensive work in August, they were able to advance 55 of their recommendations, which they will present today and deliberate on them. And upon consensus, they will vote on them publicly at this live stream. In October, they will wrap up this phase 3. And what they will do will be come back again to the public and present their final reports, which will include not only the top priorities that they are advancing, their suggested outcomes, which will be the result of their recommendations, as well as implementation. They will recommend implementation plan with accountability plan. This is a profound moment. It is a privilege for me to introduce this exceptional task force members, and it has been really an honor to work with them. They performed their charge with distinction. And with that, I am so happy to introduce Andy, who will kick us off to begin the work of this task force. The presentation will go this way. I think we can see the slide on how slide number 5, on how the presentation will go. The presentation will go with Andy, starting with proposed top priorities, and he will present the suggested outcomes, and then he will turn it over so that his colleagues will begin to share with you the amazing work they did. Kudos, and thank you so much. Andy, over.
Thank you so much, Dr. Okafor, and I'm honored to have the opportunity to talk about our priorities that we developed in the implementation work group during the phase that we've been meeting in since our last meeting as a task force. And I want to just start by thanking the implementation work group members, which included all of our ex officio members, all of the chairs of all of the subcommittees that have been meeting since the beginning of the task force. And Dr. Hildreth and Dr. Martinez were also part of the implementation work group. And I also just want to acknowledge and thank the HHS staff led by Dr. Okafor and our consultants at Deloitte, who provided extraordinary support to get us to this point. I think the charge for the implementation work group was really, we have over 300 recommendations. Can we distill them and help to answer the question for President Biden, Vice President Harris, and other leaders across the administration? What do we want you to do that we think would make a big difference in advancing lots of our recommendations across many different categories that we've been meeting on each month? And they were all laid out well by our chair, Dr. Nunez-Smith. And I just want to start, I think the overarching message to the president, the vice president, and leaders across the administration is that we want you to be bold, and we want your response to the pandemic to be proportional to the unprecedented scale of harm that we have been experiencing and are continuing to experience from this pandemic. And I really appreciated the way Chair Nunez-Smith described, I think this is one good way to describe what we're trying to do. She said that we want to disrupt the predictable pattern of who is harmed first and who is harmed worst during a pandemic. And I think that's a great description of what we're hoping these priority actions will address. We want the president and the administration to work hand in hand with communities of color and other underserved populations. And Dr. Nunez-Smith laid out all of the different groups that we have been focused on as a task force. It's a broad cross-section of folks who've experienced disproportionate harm during this pandemic. And we want the administration to work closely with these communities to transform the status quo. We believe that we have a generational opportunity to create a reimagined national health landscape that is truly equitable. So you can see on the slide, we have we have 5 specific priorities that answer the question, what do we want President Biden and leaders across the administration to do? First, we think it's important, and I also want to say for these priorities, we think these priorities are going to be important now in the current and ongoing pandemic. They're going to be important during our recovery from this pandemic, and they will be important as we prepare for the next pandemic. So the first cross-cutting priority is to empower and invest in community-led solutions to address health equity. And the key word there is invest. We want the federal government to put resources into communities and listen to the communities about what's the best way to spend those resources that would make a difference around equity. So recognize and leverage expertise that comes from lived experience in underserved communities. And make it as easy as possible for community-based organizations to access funds to solve problems. And the problems are not hard to describe. It's things like we still have issues of vaccine readiness in some communities. We have issues around access to quality healthcare, access to PPE or personal protective equipment, access to good science-based information about the pandemic as that information continues to evolve over the course of the pandemic, and access to a diverse healthcare workforce that comes from these communities. The second priority is to enforce a data ecosystem that promotes equity-driven decision-making. One of the metaphors that I think a lot of people have used during this pandemic is the idea that we're building a plane as we're flying it. Well, in order to fly a plane successfully, we need good data. We need to know what's ahead of us, what's happening on the ground, and how can we address problems as they occur. And we have not had the data that we needed to make good decisions throughout this pandemic. So this recommendation is a recognition that to make equity real and actionable, we need better data. A good example from the work that I was doing in California related to access to vaccines for people with disabilities, we did not have the data that we needed to show that there were lots of people under 65 with disabilities who are at high risk of dying from COVID and therefore deserve to be prioritized for vaccines at the same time that we were prioritizing people over 65 who are high risk of dying from COVID. But there are so many examples where we just didn't have and still don't have the data that we need to make good decisions that advance equity. So we're recommending that the government needs to collect, analyze, and share data in a timely manner, and that the federal government needs to establish and enforce equity-based standards for collection of demographic and socioeconomic data in the US Census and health data. And it's critically important if we're going to advance equity that we disaggregate the data at the individual and community level so we can identify populations that often are invisible in our existing data. We also need better data sharing across government at all levels while protecting confidentiality of personal information. The third priority is to increase accountability for health equity outcomes. Keyword here is accountability. The US must build health equity evaluation into funding, procurement, policy and budget analysis, and grants processes to incentivize, measure, and improve equitable health and healthcare. So if we're spending money as a federal government to try to improve health, we need to make sure that the money is being used in a way that improves everyone's health and that pays attention to the disparities that exist across the populations that have been affected by the pandemic. As part of this increase of accountability, the federal government should develop a health equity framework inclusive of metrics, health equity impact statements, as Chair Nunez-Smith described, and processes that can be used to hold governments and grantees and vendors accountable to health equity outcomes. As part of our evaluation process for competitive grants should be looking at what are you doing and how are you going to be accountable for advancing equity with this grant? And there should be penalties for failing to meet health equity measures. All of that is part of this priority around accountability. The fourth priority is to invest in a representative healthcare workforce and increase equitable access to quality healthcare for all. Under this priority, the goal is to prioritize the highest risk populations in response, recovery, and resilience, to grow a public health workforce and make it more diverse. So put more resources into public health, but also make sure that the workforce reflects the diversity of the communities that have experienced the greatest harm during this pandemic, and improve diversity and inclusivity of research itself. So the people doing the research and the populations who they're accountable to and working with on the research need to reflect the populations that have experienced harm during this pandemic, disproportionate harm. And then finally, the last priority is to lead and coordinate implementation of our recommendations, the COVID-19 Health Equity Task Force recommendations, from a permanent health equity infrastructure in the White House. This task force was created by the White House. It was one of the first things that President Biden did after taking office. And we think it's important because these issues cut across so many different federal agencies. We believe it's very important that the White House continue to lead the implementation of these recommendations. So if we can move to the next slide. So the priorities that I just described answer the question that President Biden may ask Chair Nunez-Smith when we deliver our final report. They answer the question, what do you want me to do? What do you want my administration to do? These outcome statements answer the question, how will we know if we've been successful? So what is the outcome that we are trying to achieve as a task force? And to the extent that we're going to look at metrics and check in and see how we're doing, where are we trying to go? What's our destination? If you go back to the plane metaphor, what's our destination that we're flying to in this plane? So these are 4 cross-cutting outcome statements that my colleagues who've chaired these different subcommittees will be able to talk about in more detail, and then they can link the recommendations under each of the subcommittees to these 4 outcome statements. So the first one is that everyone will have equitable access to high-quality healthcare. You know, that's an easy thing to say. You'll see from our recommendations, we've got a lot of very specific ideas of how to get there. And it's going to be important for the federal government to look at annual metrics and see how we're doing around equitable access to high quality healthcare. The second one, which we've already talked about in the context of the priority actions, is the data that we collect, you know, at all levels of government needs to accurately represent all populations and their lived experiences. And then the data itself needs to be used to drive equitable decisions. And again, this pandemic has shown that we don't have the data that we need to be able to do that now. And we have specific recommendations of how to develop that data and use it in a timely manner. The third outcome is that health equity will be centered in all processes, practices, and policies. So health equity is a broad concept. You get into social determinants of health, quality of life, well-being, and it's not something that can just be led by one federal agency or you know, a particular department. It needs to be baked into how we function as a society. The president is committed to health equity. The president is committed to equity more broadly. And the president recognizes that we have a generational opportunity to advance equity as a country. We want to make sure that health equity is thought about as we're making decisions about education, about transportation, about housing, about so many areas that affect people's health and well-being. And finally, the last outcome statement is that community expertise and effective communication will be valued in healthcare and public health. One thing that we've learned clearly around vaccine deployment is that the messengers matter when we're trying to convince people of the value of getting the vaccine, and the message matters. And the reason we were able to get the kind of statistics that Chair Nunez-Smith mentioned across different communities is that we've been very thoughtful about the message and the messengers. So we want to make sure that we've learned a lesson here and that this continues and amplifies over time as we tap into the expertise that exists in the communities that have been most affected by the pandemic. So let me just close by saying I'm honored that all of these physicians asked a lawyer with bipolar disorder to lead the implementation work group. I'm grateful to all the doctors for listening to the patient around health equity. And I will turn it back to Chair Nunez-Smith. Thank you.
Thank you, Mr. Imperato. Just tremendous. And the thanks are really to you for such expert stewardship of the implementation work group. We're all incredibly grateful for that. Not an easy lift, shall we say, but very, very grateful for the comprehensive, thoughtful work that was just presented for the proposed priorities and the suggested outcomes. We do have time, I believe, for discussion and these items. I open the floor now to any task force members who might want to offer a comment regarding Mr. Imperato's presentation. Dr. Martinez, please.
Thank you, Madam Chair. And I also want to thank Andy Imperato as being an excellent chair for the Implementation Committee. Honored to serve with everyone that's part of that group here, and of course all my colleagues and in the civilian as well as in the federal sector. One thing I want to bring up, because I agree with all of course what we've come up with, but in priority for the audience and for those that look at this report that goes to the administration is to recognize the impact that needs to be made to make that come into fruition, which is creating a representative healthcare workforce. We need to be looking at, our entire academic, spectrum of how we in fact are making sure there's a pipeline for folks to go into the public health, the administration of our different systems, as well as recognizing then downstream what we also need to be doing, in the postdoctoral settings, like in the residency programs, as well as ongoing, education for those of us that are already in practice. This has wide spectrum because it's not just about numbers that we need. We do need the numbers, but that educational pipeline also needs to have infusing the right skill sets, in my opinion, making sure that we have the skill sets of cultural and linguistic competency. We understand what a team-based care model approach is and how to do that well, being trauma-informed, understanding the social determinants of health, as Andy mentioned, as well as the social determinants of mental health. And also, what does it mean to have health disparities, and how do we actually start to actually eliminate those as much as we can to actually then to be able to understand health equity and achieve that, to have really which equity is about, which is about quality of care for everyone. And also the opportunity I think we can take a look at to be innovative, like our community health workers, and understanding this is a great cohort that is ready and already committed to health, that give them the opportunity to move into other health, the pipeline, maybe it, like, for example, nursing, medicine, or public health as well. So just wanted to bring that point that these are high-level, priorities, and it will take a concerted, innovative, thoughtful process to make it happen. Thank you, Andy.
Thank you so much, Dr. Martinez. Really appreciate the delineation. Just taking notes. Any other comments, task force members? Incredible. It's a great North Star. So thank you very much, Mr. Imperato, and the entire implementation work group, the work informed in that work group by these many months at this quick cadence. So it's really a thank you to everyone around the screen for your hard work to get us to that list of suggested outcomes and proposed priorities. We will be talking more about those suggested outcomes momentarily. And of course, we'll consider this for a vote later in the meeting. Dr. Okafor, back to you. Thank you.
Thank you, Madam Chair, and thank you, Andy, for always doing an exceptional job. Your leadership is amazing. Thanks.
Martha, just real quick, it looked like Tim turned off his mute, and I don't know if Tim was trying to say something.
Oh, thank you very much, Mr. Imperato. Dr. Putnam?
No, I am just gearing up for the next presentation. Just wanted to be ready.
Wonderful. Thank you so much. Back to you, Dr. Okafor.
All right, thanks. So I just excited for us to get to the details, the amazing and outstanding job the task force members have done. And with that, we start with Tim, Dr. Putnam, who will bring to our viewers and the public the work relating to outcome statements on healthcare access and quality. Dr. Putnam, please take it away and present the enormous exceptional job your team did.
Thank you, Dr. Okafor. I appreciate the opportunity to present some of the recommendations that really focus on primarily on healthcare access and quality. Just to give you guys an understanding, there are 25 recommendations. I will not read them to you, but I want to give you a background on each, and we'll go through them relatively rapidly of why these are high priorities, why they've been identified, especially after months of work from the task force and being able to bring it together. So first of all, our overarching vision is that we are a stronger nation if everyone has access to high quality healthcare. And I think that's one of the things that's really important to recognize. Not only is it vital that we and good that everyone has access to healthcare, but it makes us a stronger nation altogether. COVID has revealed that people with limited access to healthcare resources prior to the pandemic are at far greater risk of suffering from and succumbing to this disease. The recommendations are a result of months of effort, and we really tried to understand that healthcare access and quality challenges that have been highlighted through the pandemic. Some of the key themes that you're going to hear have already been presented, but just to focus on strengthening our public health infrastructure, addressing access challenges to both physical and behavioral health. And engagement with communities is really key to building a trusted healthcare system. Healthcare providers must be representatives of and empathize with the people they serve. One primary action we must take is to recognize healthcare as a human right. Too many people have been left out or continually placed at the back of the line during this pandemic. Allowing some people to be untreated and the disease to be uncontrolled, we endanger everyone. The connection between healthcare coverage and employment has created challenges today and will be problematic for any future pandemic. We need to fill in the gaps that too many have fallen into over the past 18 months and allow everyone to have access to care. Frequently, testing, treatment, immunization, and other resources were allocated through a political process, leaving several groups without the vital tools necessary to combat the disease. Allocation of resources needs to be determined based on need and in an apolitical manner. Next, we must cut waste and streamline the process to test, vaccinate, and treat patients during the pandemic. As an example, staff at vaccination centers spent more time collecting and verifying insurance information than delivering inoculations. This slowed down the process and took away valuable resources that could have been better used elsewhere. Next, the speed at which COVID-19 swept the world required our healthcare teams to care for sick and dying patients without the resources necessary to protect themselves. Having sufficient reserves and the ability to domestically produce and rapidly deploy safety equipment to where it's needed most is necessary to protect our frontline healthcare teams. Over 100,000 healthcare workers have died from COVID worldwide, and protecting the U.S. healthcare workforce must be a high priority. Outbreaks require effective contact tracing in order to understand how the disease spreads and how to reduce exposure. To be effective, this contact tracing process needs to be conducted in a way that understands and respects communities involved. Next, there are unique issues facing people in congregate settings and experiencing homelessness. Primary challenges are the inability to safely quarantine and recuperate. We must evaluate and expand effective programs like medical respite and shelter expansion to address this issue. And one key thing we've focused on is public health infrastructure. Developing a strong public health infrastructure is key to equitable response in any national health crisis. When we fully recognize COVID as a threat to the people of this nation and our way of life, we must conclude that a strong public health system is the best defense against that threat. Most minority populations are significantly underrepresented in the healthcare workforce. By not developing and encouraging these populations, we are losing out on talented people who could strengthen our healthcare system. To gain the trust of the entire patient population, we must develop healthcare providers who reflect the diversity of this country. Next, to understand the people they serve, our healthcare teams need to know more about their patients than what can be found in Gray's Anatomy. The cultural differences, the social determinants of health have a profound impact and need to be incorporated in primary and continuing education of our healthcare providers. Next, telehealth likely advanced a decade in the first months of the pandemic and was used as a very valuable tool to be able to diagnose and treat patients. In many rural areas, telehealth is the only access some patients have. Reimbursement and other limitations have caused us to lose much of the ground we gained during the start of this pandemic and lost the use of this valuable tool. We need to take advantage of the success we have experienced in telehealth and fund it appropriately. The lack of appropriate funding for Indian health service has left many indigenous and people vulnerable to disease, specifically to COVID-19. In addition to basic healthcare access, there is need for funding to support the unique environmental health concerns of indigenous peoples. Airborne and viral respiratory diseases thrive in close quarters with poor ventilation. Special attention needs to be paid to carceral settings to keep the spread of disease under control. If we fail to protect individuals in these settings, we exacerbate the pandemic and the spread of it into the settings themselves and the communities around them. Next, uncontrolled chronic disease is a key cause of morbidity during the pandemic. Correcting the root causes, such as lack of access to healthy food and safe areas for physical activity, can have a positive impact on the diseases. Minoritized populations continue to lack these basic resources and limit their chance at a healthy life. A big study that was done showed us that an ounce of prevention is worth a pound of cure. Having access to healthy food and safe physical activities is that ounce of prevention that can give many a chance at a healthy life. As we looked at long COVID specifically, we realized that too frequently specialty centers focus their efforts toward the highest paying patients. When these long COVID centers accept government funding, they should care for the whole population, and they need to share the expertise they gain with providers outside of their center, specifically with facilities that care for the underserved. Also with long COVID, we lack specific codes that categorize long COVID, and people suffering from the symptoms of long COVID have frequently fallen into the cracks in insurance coverage. Both of these issues need to be addressed. Many schools and healthcare facilities have proven that collaboration can reach teens, children, and young adults who otherwise have no access to healthcare. Building on and encouraging these collaborations can strengthen today's youth and, more importantly, the future generations. And I think that's something that we really need to recognize of what we do today makes it stronger and safer for those coming in the next generations. Next, I cannot overstate the fact that the pandemic has stressed us all. It has brought about a crisis in behavioral health. It needs to be emphasized, and the need to elevate behavioral health and recognize it as a vital part of someone's overall health is important. Increasing behavioral health resources and creating standards will strengthen our entire healthcare delivery system. We must go about the long-term work of increasing access to behavioral health care and integrating it within existing institutions. We must also see that substance use disorder is much more a disease to be treated and much less a crime to be punished. Payment rate variation between Medicare and Medicaid must be addressed. The low payments providers receive for Medicare patients substantially inhibits their ability to care for this population. Today, there are clear disparities in the type of care Americans receive. This has resulted in distrust of the system and far lower life expectancies for many of us. A solid health equity framework, which creates effective incentives, will help start down the long path of reducing these disparities. Next, hospitals that serve minoritized populations are notoriously underpaid for the important care they deliver. Rural facilities are particularly vulnerable. At the start of the pandemic, we were losing one rural hospital every 3 weeks, leaving communities without care when they needed it most. We must analyze why these essential facilities fail and determine how to make them viable and continue their important mission. We also must evaluate and expand essential health benefits to all people and create reasonable reimbursement for essential facilities that focus on serving high populations of Medicaid patients. And the final recommendation is today, we live in a nation that our elders helped build. 80% of the people who have died during this pandemic have been over 65. We must recognize this and strengthen our ability to provide care for them. All these recommendations have been developed knowing that our healthcare system is imperfect, but made up of dedicated professionals who are committed to the patients they serve. We hope these recommendations help strengthen our country and improve our ability to provide effective and equitable care to all. So, Madam Chair, I will turn it back over to you, and thank you for the opportunity to give you background on these recommendations. And I know members of the task force are prepared to make comments on these to elaborate on what I've been able to share. So thank you very much, Madam Chair.
Well, thank you so much, Dr. Putnam. Just breathtaking in scope and depth and right on target for importance. So really appreciate your leadership as our former subcommittee chair. And of course, thank you so much for bringing together under one umbrella and one outcome, all of these very interrelated and important ideas and recommendations. As Dr. Putnam said, we do have time for, yes, there are several, several folks to comment. We do have time for discussion. We will take them in order. Mr. Watts, I believe you are first. The floor is yours.
Thank you very much, Madam Chair, and want to also thank Dr. Putnam for condensing our work so concisely and yet so clearly and comprehensively. And I'd like to draw attention to one of the recommendations that is in the priorities, and then one that is not. And I have to say, I have a new saying, which Mr. Imparato picked up from Madam Chair, is that we want to disrupt the familiar pattern of who will be harmed first and who will be harmed worst. And that often is the case with people experiencing homelessness, which is in slide 18, where we want to incentivize and ensure that people experiencing homelessness are kept safe from this pandemic. I will say that this country has done more in this pandemic than ever done before. Both the CDC and HUD made recommendations to states and localities how to keep people experiencing homelessness safe. Many were taken out of congregate shelters, out of encampments, placed in hotel rooms so they could be kept safe. That was not only life-saving, but also life-changing as they got the care that they need. Unfortunately, that funding and those programs are ending, even though the pandemic is not. So drawing attention to this is really important. We say that we are only as strong as our weakest link, and that is never more clear than in a pandemic, in dealing with contagious airborne diseases, and making sure that people have the tools. Those who need it first or need it most get it first. And so there is one recommendation that will be in the final report, but it's not one of the prioritized one. I just really want to mention for a moment, and that is number 111. It states simply, states should have set aside allotments of vaccines for providers to vaccinate hard to reach populations like the incarcerated, migrant workers, et cetera. As Dr. Putnam mentioned in one referring to our recommendations, too often politics has overridden science as far as who is most at risk. And those who are at great risk, like those who are incarcerated, migrant workers, had to compete for the vaccines, even though they needed it first, because they were at most at risk. So having set aside allotments will help to remove that and will help to make sure that people will get what they need to prevent the exposure for themselves and in the larger community. I just salute this task force and thank you that these important recommendations will be forwarded to the administration.
Thank you very much, Mr. Watts. Very important. Ms. Turner, please.
Thank you, Madam Chair. I would like to emphasize the importance of investing in public health infrastructure and staffing to ensure everyone has the right to the same high quality health care. And I'd like to call upon an experience that I had a few years ago when I was called down to a little town in southeastern Minnesota. And it was the citizens of that town asked for my help to advocate to the congressman at that time, who is now our governor. And they had formed a coalition of Save Our Hospital. And I remember that the newspaper, that local newspaper at the time, showed me a picture of me, and I was going, please help us save our hospital. Because what people don't realize is these hospitals and clinics that have been closed, they are the lifeblood of a community. All major personal experiences from birth to death happen in our healthcare facilities. And it is bleeding our nation dry. Because for a decade, communities of color, low income, and rural communities have seen their hospitals and their clinics close or their services reduced. And actually, it's not stopping there, because now we're going to the inner city and closing those hospitals. And so you ask, well, where does this tie into the pandemic? Well, I'll tell you where it ties into. So we've done this practice. Our healthcare companies, who appear to be more profit-driven than patient-focused, through their closures, they have created a system where if this were a house, the plumbing is all backed up. Because we've consolidated and we're only relying on metro areas to be able to take care of all of the patients that are all the beds that are needed and the care that the patients need. We don't have enough resources throughout our states and throughout our country to accommodate. And we are backed up. I hear about one state after another, mine included, no ICU beds, no beds at all. patients being driven around in ambulances hour after hour, trying to find a place to land. And all of this has occurred because for over a decade, we have been short-sighted and we have allowed these places to close. And so I asked for our governor at the time, please help us. And now I'm asking the president and our legislators to please help us. Please bring back our community and our inner city hospitals so that everyone can have the same high quality healthcare. Thank you.
Thank you so much, Ms. Turner. Very much appreciate you sharing the very human component of all of this work, right? And it's not to be driven only by the numbers and the data, which we know are so important, but this narrative that you bring in perspective, incredibly helpful to anchor us in the critical urgency of the work. Mr. Toronzo, please.
Thank you, Madam Chair. I first want to thank Dr. Putnam and the rest of the committee, the task force rather, for voting and creating and working so hard to make these recommendations, because these recommendations will truly make a change if enacted. I want to take some time to emphasize the importance of our recommendations to recognize and declare healthcare as a human right. This task force has recognized that need to expand healthcare at almost every public-facing meeting so far. And we've carefully analyzed the many inequities caused or exacerbated by this pandemic. And nearly every problem we have addressed comes back to the inequalities created by our profit-driven and unequal healthcare system. The health inequities we have seen during the pandemic are rooted in structural problems. We've seen how healthcare being tied to employment has turned into an issue for so many people in this country, to the extent that our fragmented system of insurance was built to profit off of our health. So the task force's solutions for access and accountability in health would truly transform our healthcare system so that it is based on patient need. Therefore, it guarantees a single high-quality standard of care for all as a right. And I'm extremely glad that we recommended expanding Medicare to age 55, expanding Medicare benefits to include dental, vision, and hearing, because it's about time that we take this big step. As a young person, I want what's best for the next generations. And as Dr. Putnam put it best, the change we make now will lead to a stronger nation for the next coming generations. However, that does not mean that we can't act right now, right? So that's why I'm very glad that we've made these recommendations. And it is my hope that this administration and Congress and the rest of the federal government will take these recommendations as a next first step. That way, we can truly reach the next step towards achieving health equity by finally making healthcare a human right. Thank you.
Thank you, Mr. Toronzo. Very powerful. Please, Mr. Joseph, the floor is yours.
Before I get started, I just wanted to recognize what Canada is doing today. And I think it's really important. Today, September 30th, is a statutory holiday in Canada. This day honors the lost children and survivors of residential schools for American Indians and Alaska Natives, our Native people. Over the last few months, you've heard about mass graveyards being found outside of these residential locations. With that, today, I honor them by wearing my tribal regalia. And for them, it's important. So before I continue, I would just like to give those people that's been lost, stripping from their homes, and a root cause of many, many of our health disparities, just a few seconds of silence. Thank you. The federal government maintains a special trust relationship with American Indians and Alaska Natives pursuant to treaties, statutes, and executive orders, which includes provisions of healthcare. Indian Health Service was created because of treaty obligations. It is also the most chronic underfunded federal healthcare system and the only federal healthcare system not exempt from government shutdown or continuing resolutions, as we might be in today. The clear consequences of this chronic underfunding are the existing disparities outlined in the terms of the healthcare access, quality, housing, food security, and other social determinants of health are laid to bear by the statistics outlining the disproportionate impact COVID-19 has had on American Indian Alaska Native people and communities. American Indians, Alaska Native have witnessed disproportionate rates of infection and death during this pandemic in comparison to non-Hispanic whites. In fact, American Indians, Alaska Native deaths are infection rates and death and infection rates are the highest or second highest of any group. Recently, a letter went out to Alaskans that indicated 2 of our hospitals will be implementing crisis standard of care. In these letters, they're indicating that they may have to ration care to decide which patients have the best chance to survive when they have limited resources and not enough resources to help all patients. This is a terrible situation for all Alaskan Native American Indian people, as they have higher rates of chronic disease, diabetes, cancer, hypertension, lung disease to start with. So they will have disparities that put them in a category of patients that have significant and severe disadvantage within the medical providers. So, Mr. Putnam, committee members, task force members, I just really appreciate you emphasizing the importance of appropriate funding for the Indian Health Services. And as we move forward, also the importance of the internet and the use of the internet. Just so that you know, recently I had hooked up internet services in the one building in one of our tribal buildings. The monthly cost for that was over $350 a month. How can an average family hook up when the poverty rates in some of these communities are so high and they cannot afford it? So if people cannot afford the internet, or if they cannot afford the devices for telecommunications, we need to see and promote how they might be able to get access to affordable, reliable internet and access to the tools that could help with those teleservices. I want to thank everybody for all the work they've done, and I'll end there. Thank you much.
Thank you very much, Mr. Joseph. Dr. Martinez, please.
Thank you, Madam Chair. And I'm with you, Victor. I also want to commend the Dr. Putnam and the Health Access Quality Subcommittee for really elevating behavioral health and recognizing it is truly a cross-cutting issue. I think everyone we now know, and it is quite evident that it is played out across television sets, on social media, radio, you name it, how we're all being affected by this pandemic. In fact, it has shown our humanity. It is showing that we're emotional beings, and none of us are immune to the risk factors of what can cause depression, anxiety, and so forth, including loneliness. You know, that just so important. And some of these issues were already pre-pandemic, but they've been highlighted. And so I just want to say that also it really is time to end the stigma now. End the stigma against mental illness, end the stigma against substance use disorders, end the stigma against intellectual development disabilities. We are all in this together, and it's much time, I think, to end that. And to do that, we're going to have to eliminate these silo that we have created, artificially constructed by us due to financial streams and other methodologies, to ensure that we're having a cohesive, collective, integrated approach to what it is to be a human being. You cannot separate the central nervous system from the rest of our human systems. So I'll leave it with that, and thank you so much. Turn it back to you, Madam Chair.
Thank you, Dr. Martinez. And the stigma. Absolutely appreciate that. Dr. Khaldoun, please, the floor is yours.
Thank you, Madam Chair, and thank you, Dr. Putnam. I really just appreciate, as a public health leader and as a practicing physician, I really appreciate the work of the Healthcare Access and Quality Subcommittee and the entire task force. I wanted to raise, however, really elevate the priority around the public health infrastructure and workforce. I have spent the past 7 years of my life, excuse me, as a leader in local and state health departments. And I'll tell you, people talk a lot about, yes, we need public health workforce, we need to expand the infrastructure, but I just want to make sure people understand the reality is at a lot of local health departments, the director of the health department is also the epidemiologist, is also the environmental health director. Oftentimes, you may have one epidemiologist for an entire jurisdiction, multiple jurisdictions, or an entire state. And that epidemiologist, if they have one at all, is also needing to look at data, not just for the pandemic. We still have a lead crisis. There's still Legionella, all the other public health threats, environmental health threats, maternal infant health issues. So our local and state health departments are really struggling to do all of the things that really must be and should be done to protect the community's health. So I really just want to elevate how important it is and how dire it really is at the state and local health department level, especially, and how important it is for additional staffing and funding support. Thank you, Madam Chair.
Thank you, Dr. Khaldoun. Very important perspective there. Dr. Hildreth, please, I believe you are the last comment.
Thank you, Dr. Nunez-Smith. I want to first thank President Biden for the much needed and frankly overdue focus on health equity and for the opportunity to serve on the task force. And to thank you, Dr. Nunez-Smith, for your great leadership of this group, and to my outstanding colleagues from whom I learned a great deal. They all bring decades of passion and commitment to their work, and I've learned a great deal from them. I want to speak about increasing capacity and diversity of the healthcare workforce, something I've devoted much of my career to doing. We all know that better outcomes are had when providers are matched to the people they serve in terms of culture, race, ethnicity. And people may not know this, but between 1908 and 2008, the percent of physicians who were Black in our country never exceeded 3%. And even today, as I sit and speak with you, less than 3% of Black physicians are Black males, for example. And there's a looming shortage of physicians that's estimated to be between 50,000 and 90,000. So this would be a great opportunity for us moving forward to bring diversity to the workforce by ensuring that as we enroll students going forward and opening medical schools and expand capacity, that there's a focus on enrolling minority students, African Americans, Latinx, Indigenous people. There's a great need for that. One of the challenges we have in training more diverse is the finances of training medical students and healthcare providers, and debt is a huge problem. I want to point out that the United States spends $3.8 trillion a year on healthcare that I refer to as sick care, and 1% of that, $38 billion, would be enough to train all 90,000 medical students currently enrolled twice over. So if we just took a little bit of the money we spend on healthcare and redirected to public health and training the healthcare workforce, I think we could change this for the betterment of all of us. So I just want to point out that this recommendation is one that's really important, and I think there should be a focus on it. And there's a way to fund it by thinking about redirecting how we use our precious resources. Thank you, Madam Chair.
Thank you, Dr. Hildreth. And very important, a good note for us to pause on as we think about all of the work that's been presented so far, and importantly, representation in the workforce. Although, maybe I take those words back. Mr. Alvarado, do you have a comment?
Yeah, just real quick, this is Andy, and I just want to amplify Dr. Hilder's comment and just encourage us when we think about the diversity of the healthcare workforce to also think about people with lived experience with disabilities, including behavioral health and other disabilities, people from the LGBTQ community. I think, all of the different forms of diversity make clinicians do a better job connecting with these different communities. And sometimes the medical profession has lots of different isms baked into how they do training. So really trying to uncover those isms and make sure that all people are welcome in the medical professions, I think is going to be important moving forward.
Hear, hear. Thank you so much, Mr. Imperato. Wonderful. With that, it is 3:25 Eastern Standard Time. We have earned ourselves our first break. It will be for 10 minutes to return 35 after the hour. Just for those who are viewing, if you're interested, the slides are posted on the website. You can find that through HHS and the Office of Minority Health and the task force site. It will reconvene in 10 minutes. Thank you, everybody. All right, terrific. Welcome back, everyone. Is Dr. Okafor with us?
Yes.
Wonderful. Okay, we can resume. Thank you, everybody, again for joining. We'll continue our presentation, discussion, and deliberation regarding our suggested outcomes and finalized recommendations. Dr. Okafor, over to you. Thank you.
Thank you so much, Madam Chair. I would love to call upon our next presenter, and that will be Dr. Janae Khaldun, who will actually present on the outcome areas relating to the data analytics and research. She will present the remarkable and phenomenal work that this group did by addressing the issues relating to data shortfalls. Dr. Khaldun, please take it away.
Thank you. Thank you so much, Dr. Okafor. And I also want to really thank my fellow task force members, the HHS staff, our interns, our consultants, and of course, Dr. Marcella Nunez-Smith, our fearless leader and chair for all of their efforts leading this work. So what is our vision? And I will elevate some of the language that's already been shared today in this task force meeting. But our vision is really that we will have a robust data, we will have robust data that represent all communities and their lived experiences. And of course, we recognize, and it's already been talked about, that data are simply paramount to preventing, to understanding, and really driving mitigation of and elimination of, quite frankly, of health inequities. Data must be high quality, it must be standardized and collected and reported in a timely manner. And a critical piece of our vision for data are that they are disaggregated. And this disaggregation really allows for a more granular understanding of how different communities are impacted by public health threats, and so that resources and strategies, importantly, can be appropriately directed. Data systems between healthcare providers and public health systems, they absolutely must be interoperable, and all decisions and actions must be data-driven and centered in equity. So that is our vision for data, and we now have 10 prioritized recommendations that we think would really help the country to advance this outcome. So the first one, next slide, federal entities with authorities to set data standards really must establish standardized socioeconomic and demographic categories to improve the timeliness, accuracy, and disaggregation, which will be a theme here of data elements. And federal agencies and programs should absolutely be granted approval to collect this disaggregated data on their programs, and it must be accessible and timely available to the public. We recommend there should be a COVID-19 equity dashboard that reflects all of these disaggregated data as well. So next, we really think there must be sufficient funding, which has already been elevated in the task force meeting today. There must be sufficient funding to ensure an equity-centered approach to data collection. It's so important that we not only have disaggregated data on race and ethnicity, but also across other marginalized and underserved groups. That includes those who may have disabilities, those who are involved in the justice system, many other people, people with who may not have English as their primary language. It's so important that we include data on those groups, and any administrative barriers to achieving this goal really should be removed, and all federal agencies should be fully supported to be able to implement this. Next slide. To support the collection of robust and standardized data, the federal government really should provide funding or incentives to advance data modernization initiatives for all hospitals. That includes the VA, community health centers, and our state, local, tribal, and territorial departments. Data systems must be interoperable between health systems. I'd also add between doctors' offices and public health departments. We have to get away from fax machine reporting between hospitals and doctors' offices and public health departments. And it also needs to include, importantly, automatic lab reporting. that's something that is so critical, and it was missing, especially early on in the pandemic. And that's why we really got behind and did not understand how the virus was spreading across the country. And again, I have to emphasize the importance of standardization and timely collection and sharing of this disaggregated data. We also recommend that the federal government should create health surveillance surveys across race and ethnicity, education, economic and linguistic diversity, really to inform health equity-based decision-making and actions. So all levels of government really have to identify and leverage existing sources of quantitative and qualitative data. We are certainly not starting from scratch. The inequities, the disparities we're seeing in COVID-19 were not a surprise. They were expected based on what we already know and the data that we already have. So it's really important that those data sources and systems are also accessed. So this can include data from Medicaid programs. It can include data from EMS or other systems within a public health department. And also, this was really, really important. You may not be able to do a randomized controlled trial. You may not have robust health and surveillance data, but that absolutely should not prevent health authorities from prioritizing resource allocation to groups who have increased risk for infection or severe disease or death based on their underlying health conditions or other risk factors. So unfortunately, we also know that individuals living in congregate settings have been disproportionately impacted by the pandemic. The federal government should work with state, local, tribal, and territorial health departments to establish efforts to track and report on the health status and outcomes of people living in these settings. So again, this includes those carceral settings, those long-term care facilities, foster care facilities, group homes, as well as homeless shelters, and specifically interventions like decarceration and a safe relocation of those who are at highest risk of dying during a pandemic absolutely should be researched, developed, and implemented. Next slide. There must be a national research agenda that is currently lacking, and that research agenda must be centered on health equity and COVID-19, and it must center health surveillance and analysis of population health data. We absolutely support public-private partnerships, community-based participatory research, and over-representation of historically underrepresented groups. And we also really want to highlight the importance of representation of communities of color and individuals across the lifespan, the very young and our older populations. And so on the next slide, just building upon that, we also want to make sure that we have better representation of communities of color in clinical trials and all underserved populations, quite frankly. The federal government really must develop standards and set diversity enrollment targets for clinical trials. And this is important not only to assure that treatments and interventions are effective in diverse populations, but also to promote community acceptance of them. Next, we also have talked about behavioral health. We want to emphasize the importance of behavioral health and building out a data infrastructure to understand the intersection of behavioral health with the pandemic. Government really at all levels should invest in a data infrastructure to collect, integrate, and share data related to behavioral health, including the continuum of prevention, testing, treatment, and service utilization. And again, I'll say it again, the importance of standardized and disaggregated data is just critical to driving an understanding of how the pandemic is impacting communities at a granular level to really drive equity-centered decisions. We also recognize that racism does exist, and it exists in our healthcare system. And as such, the federal government should actively fund and promote practice-based research that seeks to minimize and ideally eliminate structural racism, sociocultural, economic, institutional, and interpersonal discrimination in the healthcare system. Absolutely should be an assessment of clinical practice guidelines, of health-related algorithms, artificial intelligence, technologies. All of these have discrimination present in them and clinical practices as well. And we really must make sure that communities of color and other underserved communities receive high quality, just treatment in the healthcare system. So absolutely, we must address racism in the healthcare system. And then finally, our last recommendation on data really focuses on schools. We recognize the importance of in-person learning, but also recognize the importance of doing so safely and to mitigate the spread of COVID-19 and other infectious pathogens in schools and surrounding communities. So we're recommending an equity-centered implementation research around the effectiveness of non-pharmaceutical mitigation measures like social distancing, masking, improved ventilation, all the things that we are asking our schools to implement that we have some data about, but we absolutely think there needs to be more research around them and other interventions that prevent transmission. And also not just preventing transmission of a virus, but also their impact on educational outcomes for children. So all levels of government and school districts should absolutely work together in both developing and, importantly, enforcing mitigation plans based on these evidence-based measures. And we also think that educational agencies should be funded and incentivized to adhere to these mitigation plans. So, and I just want to thank my former subcommittee members, all of the members of the task force. And with that, I will turn it back over to you, Madam Chair, for further discussion.
Thank you so much, Dr. Khaldoon. I was here writing down the vision. I love that vision for that data that will help us make better and more equitable decisions. And I so appreciate your mantra. I don't think you can say it enough. Disaggregated data, right? So important. So thank you again for your leadership of our former subcommittee focused on data and analytics and research, and for bringing again this body of work together under this one umbrella related to this key outcome. Really spectacular. We do have time for discussion, as Dr. Khaldoon mentioned. It is open to any task force member. Mr. Imperato, please, the floor is yours.
Thank you, Madam Chair. I just wanted to mention that sometimes collecting data on disability can be expensive because you have to ask a lot of questions to get meaningful data that identifies the population. And I just want to point out that under the Clinton administration, there was a disability supplement to the National Health Interview Survey that was administered in 1993 and 1994. And it has not been re-administered since then. And we got a lot of very good granular data out of that. So I just, as we think about our comprehensive approach to data and requiring more data, just recognize it would be helpful to have regular deep dives around disability data, like the supplement to the National Health Interview Survey that happened in the early 1990s. Thank you.
Thank you, Mr. Imperato. Very helpful. Dr. Venters, please.
Thank you, Madam Chair. Thank you, Dr. Khaldoon. Thank you, Dr. Okafor, and all the incredible colleagues that have been part of this task force. I've learned so much from. I just wanted to underscore the problems that I see with the data gaps in carceral settings, not just around COVID, but around a whole range of health outcomes, including the most serious outcome, death, where we really don't know when a person dies behind bars the answer to two crucial questions. Did they receive the standard of care? And did anything that happened behind bars, including medical neglect, contribute to the outcome of death? And we don't know those things because these systems are designed to be opaque, to avoid transparency. And so that continues to be the case with COVID. Just in the last month, I continue to see in facilities people with COVID being put into small cells with people who do not have COVID, and just scores of cases coming out of that. I see facilities not testing people on the way into facilities, I believe because nobody wants to know how bad this problem is in some cases. But I do think that we have an incredible opportunity here. The CDC and local and state departments of health have worked more with and in correctional settings in the last 18 months than they probably ever have. Maybe some exception with the MDR-TB outbreaks and other small outbreaks. But we have an opportunity here to do the right thing, which is to get these evidence-based structures involved in tracking health outcomes, not just around COVID, but around diabetes, around death, around injury, and build a system that's honest about the health risks of incarceration, as well as the health of incarcerated people. And so I am hopeful that we can act on this opportunity in a way that legitimately addresses this longstanding evidence of racism in health. Thank you.
Thank you, Dr. Venters. Really appreciate you bearing witness and for the work that you're doing and bringing that perspective here for our deliberation. Dr. Hildreth, please.
Thank you, Madam Chair. I'd just like to speak to the importance of data generally. We all recognize that data empowers us to make good decisions, as well as to make the most efficient and best use of resources, especially when the resources are limited. There are examples of this that abound across many disciplines. The large healthcare systems and payers are rushing to establish large databases of patient data and analytic capabilities with the hopes of improving outcomes and lowering costs. But many of those large data sets do not contain many records from folks who look like me, which means that the algorithms they will derive will not be beneficial to people who look like me. So that means that the power of data will not benefit all of us. And as a scientist, data generation and analytics are at the heart of what we do. And decades of data accumulation, starting in 1961, actually, with mRNA, and data sets from large viral genomes, from the immune system, clinical trials, all made it possible for us to enjoy these safe, effective vaccines that we're taking right now. So the other thing is that data collection was critical from the beginning of the pandemic because we needed it to make an invisible enemy visible. Likewise, there are people among us who are invisible because we're not collecting data on their plight. And so we can't achieve the goal of all of us having our best health unless that information is available. So I just want to emphasize that data is critical in so many ways. And I think this recommendation warrants special emphasis. And I just want to raise that up. So thank you for that opportunity.
Thank you very much, Dr. Hildreth. Appreciate it. Mr. Joseph.
Thank you. Just really appreciate Dr. Khaldun and all the work she did and all the people and everybody attached with all the HHS staff. Some of our TECs, our tribal epidemiology centers, are still having data access challenges in getting adequate health data. Our TECs need public health data to assist tribal nations save lives and achieve health equity. We must have a single interpretation of the Indian Healthcare Improvement Act, specifically around the author where it defines the 12 TECs, our tribal epidemiology centers, as public health authorities for the purpose of HIPAA privacy rules for data sharing that all HHS agencies should follow. Madam Chair, that's all I wanted to say. Thank you.
Very much appreciate it. Thank you, Mr. Joseph. Ms. Johnson, please.
Thank you so much, Madam Chair, and thank you, Dr. Khaldun. I want to both underscore and amplify your message as well as the comments made by Dr. Hildreth. The importance of data cannot be understated. Coming from the perspective of the federal agency that was asked to lead the effort to vaccinate the country, in the early part of vaccine rollout, we were very successful in reaching communities of color, those that were hardest hit because of the use of data. We used it on a literal daily basis to change strategies to make sure that our outreach was effective in reaching those communities. And I want to share the outcomes that FEMA reached as a result of that. During the period that FEMA had community vaccination centers, we opened a total of 39 community vaccination centers across the country. The outcome of collecting data revealed that we were able to vaccinate close to 60%, 59.3% is the exact number as of the cutoff date of our collections. 59.3% of the vaccine doses administered at those community vaccination centers went to racial and ethnic minorities, as compared to only 40% of the vaccine doses administered in those states at non-CVC centers. And very much the difference was collection of data on a daily basis that led to decision-making on a daily basis about where outreach, where pop-up clinics, where mobile units would go. It cannot be understated how important this is, and I really appreciate all the work of this committee. Thank you.
Thank you so much, Ms. Johnson. So glad for you to elevate that and appreciate your leadership. And of course, all FEMA did to get to those outcomes with intentionality. Equity never happens by default. So thank you very much for that. Ms. Turner, please.
Thank you. I want to thank my colleagues for supporting recommendations to address racial and other biases in clinical practice, algorithms, technology, and practice guidelines. And, you know, we all talk about how we've learned so much from each other on this task force. And probably one of the most eye-opening for me was having the validation that I see at the bedside that when I'm taking care of patients, that the treatments just don't seem to be working. And as an ICU nurse, having to make one call after another because this blood pressure medicine doesn't work on this person or whatever, and only to find out that it's algorithms and it's guidelines that we're following, and the source of frustration that I have felt through the years, because I see at the bedside what inequities have done to my patients. And as an ICU nurse, I at least have the ability to call the doc up at 3 a.m. and go, this isn't working, I need something else. And I'm gonna keep bugging you until I get what I need for my patient, okay? And so the idea that we will start to look into the racial biases that are embedded in our algorithms, our guidelines, and our technology is so important, because decisions should be patient focused. It shouldn't be on their patient profile. And decisions should also be up to the individual practitioners, the nurses and the doctors who are making the observations. And so I really want to, guys, this has been a huge eye opener for me, because I see at the bedside, and I'm realizing at the bedside that I'm not able to do the best job I can because I don't have the tools. There are biases embedded that are keeping me from doing my job to the best of my ability, and that is intolerable. Thank you.
Well, thank you, Ms. Turner. Please never stop bugging, never stop advocating, never stop caring as deeply as you do. It is appreciated. Mr. Watts, please.
Thank you. I really want to underscore and the importance of collecting data and disaggregated data, which you said is a new mantra, and just want to congratulate FEMA for collecting the data on that early on. But unfortunately, that was not the experience across the healthcare setting, and we had a lot of missing data on race, ethnicity, and language around COVID testing, vaccinations. Partly when we have missing data, I want to quote phrase from a subject matter expert that addressed us before, that missing race data is a form of racial oppression, and you can substitute any type of oppression missing that data in there. So data is missing. It's sometimes because it's not asked. So we have to make sure it's asked. You know, there are ways to put it in, to ask that question and collect it, but sometimes it is required or asked and it's not filled out. So that really is a matter of accountability at several levels. The funder, the federal government, if it's going to the states and saying, we want you to collect this data, if they don't, it goes to another word of ours about accountability and also incentivizing, perhaps rewarding for collecting that data. And also, I can say this as a longtime executive director of a federally qualified health center, sometimes individual providers don't do that. And then it really is up to the leadership to say, no, we need this data, and explain why it's important for quality and important for equity. So it's important to say we want to collect the data, but we also need to have accountability so that we don't have missing data. Thank you.
Thank you so much, Mr. Watts. Really appreciate that, because you said some key things there. Along with the accountability, which is needed, we also have to be sure people understand the key importance, right? That education that you mentioned, that campaign, so people understand why these variables are so needed. Thank you. Ms. Yoon, please.
Thank you, Madam Chair. I want to echo the appreciation to Dr. Calhoun and her leadership in really thinking through these robust set of recommendations in relation to data. I just want to underscore the importance of disaggregation. So I know in other arenas of our lives, aggregation and coming together as one community is so important. But I think when we think about health equity and data collection, disaggregation is so critical. I think oftentimes that aggregation masks diversity of experiences, which results in masking diversity of inequities that different communities experience. And so I think that is particularly on point as this task force was also looking at the rise of anti-Asian violence and xenophobia as it applies to a diverse range of Asian, Pacific Islander, Native Hawaiian, indigenous communities across the United States, that it is so important for the disaggregation of data and make that connection to our policymaking to address and achieve all the vision and the outcomes we're talking about today. So just wanted to underscore that, and thank you so much.
Thank you for lifting that up, Ms. Yoon. Much appreciated. Wonderful. I believe that's the last comment on that, on those slate of recommendations. So just thank you again, Dr. Calhoun, and everyone involved with getting us to that tremendous place in presentation. Very much appreciated. Dr. Okafor, back to you, please.
Thank you. Thank you so much. This, I hope our viewers are really taking this in. It's a profound moment. Showing the exceptional work of the team. I cannot thank every one of you enough. And I want to really call upon the next outcome area, which will focus on our structural drivers and xenophobia. And I'll call Hye-Young to present on its so remarkable, and it's also very unprecedented because many people talk about structural drivers and it's just huge. So it is amazing to see the work that this team put together. Hye-Young, please take it along. Thank you.
Thank you so much. And I just want to start by expressing my deep gratitude for all the members of the task force who tirelessly worked together and came back literally every week and to talk and engage and develop these recommendations. And obviously, of course, also the entire HHS team under your leadership, Dr. Okafor, and also in terms of our consultants and the interns we've had. So really deep appreciation. So can we go to the next slide? So we have 14 recommendations under structural drivers, and these 14 recommendations are to accomplish the outcome that Mr. Imperato talked about in terms of baking equity into everything we do and everything this administration does, from processes to practices and policies, right? And so centering equity can yield communities that have and continue to experience long-standing inequities in the arenas of health, the environment, in the labor force and the economy, including working under hazardous conditions. They will be able to thrive and prosper. So the vision that we are working towards through these set of recommendations are that people will receive the best possible healthcare, education, economic opportunities, that communities of color and other underserved populations will no longer experience the disproportionate burden of adverse health outcomes, whether that is short-term or long-term related to COVID. And as a nation, and as our chair, Women Tech, we will disrupt the predictability of who is harmed first and who is harmed worst. And that at the end of all this, that all communities will have the resources that enable them to prepare for and recover from pandemics, and that we will not and cannot leave anyone behind. So under those incredibly important vision, we have the following recommendations. The first we begin with, so given that this committee came together under the structural drivers, we really looked at the social determinants of health and well-being, which means that really looking at every aspect of people's lives to make sure that we are lifting up and making sure we are setting up people to succeed and have all the needs met. So the first is really looking at making sure that all communities across the country have affordable broadband access. As Mr. Joseph talked about, that the cost of internet is over $350 where he lives, and I pay, where I live in New York City, is $30 a month. It's just simply incredible in terms of the disparity that we have across the country. So it's really seeking the federal government to strengthen access to affordable broadband in the underserved communities, including rural and tribal communities, to minimize the barriers to accessing medical, mental health, and substantive use order services via HealthHealth and HealthMedicine. This recommendation including allocating funding to address the internet deserts. Next recommendation is really talking about housing. So the federal government should take the action to increase both the supply of high quality, affordable, accessible, supportive housing, and to strengthen the programs that enable people to remain in their homes and houses during a public health emergency. So this includes renewing the eviction moratorium, the rental assistance, funding for legal services to prevent people from being evicted, right? Getting this legal support, expanding housing first programs, strengthening housing and lending anti-discrimination laws, and prohibiting disqualification of public housing vouchers based on criminal and drug history. The next recommendation really looks at the need that we need to invest in our workers and working families. There's no question that the last 18 months have been real struggle for workers and working families, especially those who work in low-paid service industries who we deemed as frontline essential workers who went to work during the shutdown processes. So as we are still in the pandemic, but on our way to recovery, the administration should work with Congress to for an economic recovery that creates good jobs. That means paying family-sustaining wages, people having access to benefits, strong protections, and have workers to have a strong voice in their workplace. It also means that investment in childcare, paid leave, home and community-based care, and other family care supports and services that allows workers and working families, especially women of color, communities of color who've been disproportionately affected by the pandemic-induced recession, to go back to work and really contribute and grow our economy. Next slide. We're also talking about advancing cultural responsiveness and language access towards Asian Pacific Islander and other populations facing pandemic-fueled discrimination and xenophobia. So there are 6 specific recommendations that we're talking about. It will be on this slide and the next slide. The first 3 are requiring federal agencies to make communication transparent, culturally and linguistically inclusive, allocating sufficient funding to federal agencies to review enforcement of anti-discrimination protections and implement solutions to address any gaps in both the investigation and the prosecution of discrimination complaints and cases, and enforcing anti-discrimination protections for Asian Pacific Islander and Native Hawaiian healthcare workers who've experienced harassment, discrimination while trying to provide much needed healthcare services. The next slide has 3 additional recommendations under this, which are supporting teachings about the experiences of Asian Pacific Islander, Native Hawaiian, other communities who face xenophobia and rise of discrimination, so that there's more shared understanding of different experiences that we all are facing as one nation. Mobilizing action plans to quickly respond to discrimination and hate crimes, as we saw in this pandemic, and using an equity-centered approach to create future pandemic plans to combat any discrimination and xenophobia. Next slide. The next recommendation is really talking about how do we support schools to meet the family needs. So the federal government should expand schools' ability to meet children and families' holistic needs, including those related to COVID-19. These strategies include investing in full-service community schools that provide one-stop shop access to social services like educational, social emotional development, physical health, mental health, and expanding programs that provide students access to free meals and other supportive services, even while schools, if the schools need to close. The next is also talking about the importance of investing in virtual education system and infrastructure, that the government should provide sufficient funding for appropriate technology, training, supports to students, teachers, faculty, to enable the continuation of quality education and other services where schools must shift between in-class and remote learning. The next is also talking about making post-secondary and workplace training more affordable, that the government should increase funding for financial aid programs and implement loan repayment pause programs during future pandemics to address attrition, affordability of post-secondary and workplace training programs for students from communities hardest hit by COVID-19. We also need to really protect our workers in order for our economy and our communities to recover fully, right? So one of the hardest things that we saw through the pandemic was that workers were going to work despite being exposed to hazardous conditions. So really calling upon the federal government to use its authority under the Federal Occupational Safety and Health Act and other authorities that may be available to them to protect all workers from exposure to hazardous conditions during pandemics, right? This also involves the government developing an emergency response plan to assess and quickly meet the needs of healthcare and essential workers. And it's also encouraging government to work with private sector employers to provide paid time off, wage replacement programs to account for future pandemics related to that, allowing workers to go test on a timely basis, go get vaccines and have time to recover. That this does not in any way substitute what the federal government needs to do, but this is but importantly, to partner with the private sector employer community to do their part. Similar to this is just, again, I think not just in the workplace, but in broader congregate settings, making sure that there's safe ventilation practices and there's a regularly evaluation of such practices so that everyone, whether they're in congregate settings, whether they're in workplaces, are all safe and living safely. We've also talked about the importance of making sure we accomplish environmental justice, that the government has a role to play in extending its commitment to environmental justice during pandemics, to ensure that there's access to clean water and sanitation, establishing a low-income utility assistance program, using, again, disaggregated data to assess exposure to hazards, and based on that, allocate utilities, developing and modifying water, sewage, and air quality standards, and instituting a moratorium on water and utility shutoffs. We also talked about that during public health emergencies, the federal government should use its full executive authority and work with Congress to provide safety nets and to implement them effectively and efficiently to ensure that all people have food, housing, shelter, and economic security and receive the support with healthcare-related travel, lodging, and caregiving needs. Our last recommendation is talking about the importance of access to good food and to have food security. So creating funding and incentives to research, identify, and implement interventions to support communities that have limited access to healthy food options. This includes expanding federal nutrition safety net programs and using technology to make those programs more accessible. Those are the entirety of our recommendations, and I turn it back to Madam Chair.
Thank you so much, Ms. Yoon. You know what Dr. Okafor said at the beginning, you know, this is not a small ask, right, that was made of you to chair a subcommittee focused on all of the structural drivers as well as xenophobia. And so I want to say an extra thank you for your leadership as chair of that subcommittee and to all the members who contributed to that work. And of course, to where we are now, bringing the work together, umbrellaed under that suggested outcome. Really impressive breadth and depth and scope and laser focused. So thank you so much for that, as well as the outstanding presentation. The slate is open for discussion to any task force member. Dr. Khaldun, please.
Yes, thank you, Ms. Yoon, for your presentation. I wanted to elevate the importance of the recommendation on giving a priority of high living wage to people. And really just when you don't do that, it has consequences, not just for that family, that person receiving that wage, but also for the entire system, not just the healthcare system, but the behavioral health system. And it actually exacerbates the disparities that we see. For example, in Michigan, we've had adult foster cares that have closed because they don't have staff. It impacts our nursing homes, or we now have patients who can't be discharged to a nursing home because there's not enough staff, so they have to stay in the hospital. So there are just so many consequences of not paying people a respectable wage. So I just really wanted to elevate that and the importance of that as far as addressing inequities.
Thank you so much, Dr. Khaldun. Yes, Ms. Johnson, please.
Thank you, Madam Chair, and thank you so much, Ms. Yoon, for reflecting the hard work of the committee that you chaired so valiantly. There was so much that was tackled by this group. And as I was listening, although I participated in the conversations, I was still struck. I was struck by the breadth of the recommendations. And what it made me think about was the pandemic really revealed some very serious structural fissures in the foundation of our country. I know that everyone on this task force realizes that, but I don't know if it's appreciated across the country. We have systemic failures. We have to have systemic fixes. It is not enough to simply identify small fixes. We have to attack these issues head on, and the breadth of the recommendations are just truly expansive in nature, but I think it gets to what matters most. It gets to supporting and filling in those fissures, building up the structure to support families, to support workers, to support individuals, to support communities, so that we can all move forward more effectively. As I was listening to you, Hae-young, I thought we really just can't go on in this manner. We have to address some of these systemic failures in order to move forward most effectively as a country. So thank you again for your leadership.
Hear, hear, Ms. Johnson. Thank you so much. Dr. Martina?
We have to as a country.
One sec.
Thank you, Madam Chair. And thank you, Hae-young, for chairing the SDX committee. Wonderful job, and agree with the comments made already. One of the ones I want to highlight really is how telemedicine and telehealth really have come to the forefront. For a long time, it was seen as pilots, or we could only do so much. And the pandemic showed that actually we can be quite innovative and we could elevate the utilization of that. But behind that, as was pointed out in one of the first recs, is that broadband, the infrastructure that is needed for technology in this country. We're the 21st century people. We need to really realize, as a technologically, centered now economy, that broadband is actually now a basic utility. It's like water, electricity. We need to make sure every corner of the United States has it, because it's not just health that's being impacted. It is also important and integral to education, as been shown during the pandemic, and important and integral to commerce. So let's move the ball forward and ensure that we're able to address all these huge systemic issues. And so that infrastructure needs to be there. Many states and the federal government are looking into this, but we need to really accelerate that. We're behind when it comes to, in my opinion, to some other countries, the ability they have to really utilize that infrastructure. But the telemedicine and the telehealth, what it also did, though, it did increase access geographically, as well as to certain sectors like homebound folks, mobile units that can take, a Wi-Fi and the telemedicine, telepsychiatry on the road, so that we can address homeless individuals, our veteran population. My wife is a PharmD who actually does telepharmacology embedded with the internal medicine unit, but from afar with veterans across the board, and they love it. The VA has been on the forefront in many respects in some of this. So we have exemplars that we need to raise up and come across, because we need to broaden the toolkit, not restrict or limit our toolkit. It's not the end all. We know that as clinicians, but boy, golly, it can really make a difference. Thank you, Madam Chair.
Thank you so much, Dr. Martinez. I love the nod to exemplars. That's right. We do know where to look to get a better idea of how we can do better. So thank you for that. Mr. Watts, please.
I want to thank all of the task force, and also want to thank Ms. Johnson for her comment that we have structural problems, and unless we have structural solutions, we won't achieve equity as we need it. And one of the important areas, which is reflected in the recommendation on slide 55, increasing affordable, accessible housing, is extremely, extremely important. Housing is one of the strongest social determinants of health. And this recommendation talks about increasing the supply of affordable housing long-term, as well as protecting people, helping to keep people in their homes during a pandemic. It is so important. Matthew Desmond, in his book that won the Pulitzer, Evicted, shows the human and societal cost of one single eviction on what it does to a family. It knocks them down several rungs of the socio-economic ladder. For those who are on the lower rungs or just hanging on, it knocks them off completely. Some will never, ever recover. And on October 3rd, the eviction moratorium is scheduled to end. We are facing a crisis of millions of people potentially facing eviction. This is a public health crisis, a human crisis, and we need to keep people in their homes during the pandemic, which is not over, and we need to increase the long-term supply of affordable housing. This administration campaigned on ensuring there will be a housing subsidy for everyone who qualifies. Right now, only 1 out of 4 households qualifies because of lack of funding. That's the only reason, lack of funding. So we hope that the administration and Congress will do what we need to protect the public's health, protect people and our communities. We need affordable housing, and I'm glad that it's here, and I hope that it will be implemented. Thank you.
Thank you so much, Mr. Watts. Much appreciated. Ms. Turner, please.
Thank you, Madam Chair. So as a frontline worker who's been working in a COVID ICU for the last year and a half, and as I continue to do, I appreciate how this subcommittee has made recommendations to strengthen the worker health and safety protections. I mean, I have beat it to a dead horse as far as PPE. Everybody knows it. Whenever we forget to talk about it, I'll bring it back up again. And, you know, when I haven't been working in the COVID ICU, I've been out with other organized labor fighting for protections. I've been in pickets in the rain. I've been in pickets in 10 below weather, outside of hospitals, outside of government areas, begging and pleading for proper protection. And the reason I've had to do that is because we have had, through the beginning of this, until the emergency temporary standards came in, we had OSHA guidelines that are not enforceable. And so this recommendation to bring forth and change something that hasn't been changed in decades, bring forth OSHA standards so that it can benefit all workers. Because I'm telling you, before so many, and when I think of the meat packers that I stood next to and listened to their stories, and the people who cleaned our buildings, and the people who brought our food, and I would hear stories in all different languages of the hardships and the death that was going on because they were not properly protected, because their places of employment were following guidelines, which means they didn't have to necessarily protect them. And how many deaths could we have saved? How many people could we have saved if we would have had standards that from the very beginning, our places of employment had to keep their employees safe? Please, please, President Biden and all the officials in Washington, please bring about a change that will benefit all workers across our nation. Make them standards and not guidelines. Thank you.
Thank you very much, Ms. Turner. Ms. Alvarez, please. Ms. Alvarez, I'm not hearing you. Are others hearing her? Try one more time with your audio, please. Not yet. Do you want to call in as well for audio? We'll circle back. Thank you. Mr. Joseph, please.
Thank you, Madam Chair. I want to talk about the importance of clean water and utilities, as well as supporting those essential workers. When we look, I'm just wanted to give you some comparison that we're dealing with here in Alaska. A per kilowatt hour costs about 54 cents here in comparison to the national average of about a little over 15 cents. To bring water into a home, if we're lucky enough to have water into a home, it's about $140 per month. And then fuel oil costs about $3.25 per gallon, and each home would use about 150 to 200 gallons, making that about $450 to $600 cost. When you look at approximately 6% of American Indians, Alaska Native households lack access to running water. In a report by the Environmental Conservation, that over 3,000 Alaska rural homes and approximately 32 predominantly Alaska Native villages lack running water, forcing the use of honey buckets. If you don't know what honey buckets are, they're a nice little 5-gallon bucket in your house that you get to dispose of all your nasties in, and then haul it out and dispose it. And so as we look at that, it's really important and essential that, especially during pandemics, where emphasis on washing your hands are so important, that people have access to clean water in their homes. And that's going to be essential and a need. And when we look at some of the prices in comparison to others around the nation, we need to make sure that people are able to keep their jobs in order to keep their homes going. Because if they lose their job in the middle of winter and they're not able to afford to pay the electric bill, let alone their internet connection, people have to make some really tough choices. And this goes across our nation. And so we need to be thinking about them during these times. And I just really appreciate all the work that Ms. Young put in and with all the other members. Thank you.
Thank you, Mr. Joseph. It's harsh realities. Ms. Alvarez, should we try again? I do not hear you. We're still not hearing you. Are you also on a phone line? All right, we'll circle back. We have Dr. Hildreth and then Ms. Gleason. We'll keep working to solve those tech issues. Apologies, Ms. Alvarez. Dr. Hildreth, please.
Thank you, Madam Chair. I'd like to bring special emphasis or re-emphasize a point that my colleague, Dr. Martinez, made regarding broadband access. Here in Nashville, Tennessee, which is one of the healthcare hubs of the nation, we have large hospital systems that when the pandemic started, they could quickly pivot to telemedicine and telehealth to treat their patient panels. We take care of primarily uninsured and Medicaid patients, and we discovered that there's a technology gap in which we could not do that for our patients because they didn't have access to the technologies that the patients of the large hospital systems had. Now, fortunately, we got grants from the FTC and other agencies to help us fill that gap. But I want to make the point that some people believe that the broadband problem is a problem for rural areas and tribal communities. Well, that is not the case. It is also a problem for poor communities and urban communities in certain cities. And so I really do agree with my colleague that this should be considered like running water and other utilities, because we're not going to close the education gap or the medicine gap or healthcare gap without doing so. So I just want to point that out and thank you for the opportunity.
Thank you so much, Dr. Hildreth. Ms. Gleason, please.
Thank you. And thank you, Madam Chair, for bringing us all together and running this task force in a way that gives us all a place to learn and to experience all these different viewpoints. I will say that as somebody who's been in the Department of Labor for several years, I very much appreciate the recommendations that have come through this particular subcommittee. It's really heartening to me to hear the level of care. I've spoken to Mary a number of times about OSHA standards and worker protection standards, and we've gone back and forth about that. But also, it's really heartening to me to hear this level of support for the federal minimum wage, for people being able to pay, for people to be able to earn a living wage, which will help so much to stem the tide of the evictions, which will help so much for people to be able to afford access to care. I don't know that in this country, when we talk about the federal minimum wage, we really think about all of the ways that it makes a difference for that particular family, for those particular incomes, for people to stay afloat. And to raise the minimum wage, which has not been raised in decades for people, it just has such a potential to help in so many different ways to resolve a lot of the inequities that we're seeing. So I'm just particularly heartened to hear that my colleagues here are so supportive of this. I know that it's something that we don't necessarily run into all the time. I know that this has been a source of great debate, and it's really fantastic to know that I've had the opportunity to work with such an amazing group of people who, when it comes down to it, we're all here trying to make sure that we're meeting the needs of the American people. So thank you, and thank you all for the opportunity to participate and learn on this committee.
Thank you so much, Ms. Gleason. Thank you for your participation, your perspective, and for your joining and being part of our task force family. Much appreciated. Ms. Alvarez, third time is the charm. Please, the floor is yours if the audience is cooperating.
Can you hear me?
Yes.
Great. I'm so sorry. Clearly, it's been a while. So thanks so much for the opportunity to comment. First, let me say thank you to Ms. Yoon for her presentation and her leadership. I'm going to also build on Ms. Johnson's and Mr. Watt's comments for two quick comments. One is, coming into this work and looking at structural drivers as one of our priorities, it's very easy to fall back and feel defeated because these issues are so big, these challenges are so hard, and they've been around for so long. And yet we still took that on, and we still are constantly trying to learn and find new ideas, listen to community, find ways in which government can do better by its people by addressing these longstanding inequities. And I just really want to commend the group, commend the staff, the team for sticking to that commitment and ensuring that if we really want to be prepared for the next pandemic, we must seek to address these underlying inequities that have plagued our communities for far too long. So that's just my first comment. I really want to acknowledge that and be grateful for all of the work that went into these very comprehensive set of comments. And then my second one, I just want to emphasize the importance of supporting schools and really meeting the comprehensive needs of our families and our children. I think if you look across the political spectrum, across the world, across the economic spectrum, we prioritize our kids across the board. Everyone wants our children to be healthy, to grow up, and lead the lives that they deserve. And when it comes to our schools, that's where so many of our children are spending the majority of their day. And recognizing now how hard hit our kids are becoming as a result of COVID-19 and its impact, making sure that where they spend their time is as fully supported as possible is such an important priority and such an important goal to put in place. Particularly when it comes to considering the health impacts, the mental health impacts, the impacts on hunger, on safety, and what schools really need to take care of our kids. So I just really want to acknowledge that commitment as part of this recommendation and really speak to the important role that government and working in partnership with states and communities have in making schools the comprehensive family resource centers that they truly are. Thank you.
Thank you so much, Ms. Alvarez. Spot on, very powerful last comment for that slate of recommendations. Very much appreciated. So thank you all for that deliberation. Ms. Yoon, thank you again for the presentation and for your leadership. Dr. Okafor, I will pass it to you.
Thanks, Madam Chair, and thanks to a remarkable presentation we just heard of amazing work done. I'm going to call on the chair to present, one of our sub-chairs to present on the outcome area relating to communications and collaboration. This particular area is so critical because it brings forth the prominence of working with the community. So not only is their work prominent, but it's also distinguished in a way because it lifts up recommendation to address the communication, the misinformation and disinformation. So I will turn it over to Myra Alvarez. If you could take it on and present. Thank you.
Can you hear me or do I need to press *6 again?
You've got it. We can hear you perfectly.
Got it.
Ms. Alvarez.
Thank you. Thank you so much. Thank you, Dr. Okafor. And I also want to extend my deepest appreciation to my fellow task force members, the HHS staff and interns, our consultants, and the leadership of Chair Nunes Smith, as well as the many individuals and organizations that lent their expertise these last 6 months through presentations, sending resources, and providing public comment. As we discuss how we are advancing equity in our response to COVID-19 and how we are working to advance health equity, I just want to say I feel personally grateful to this group and its goals. I was fully supported in my commitment to spend the last 3 months with my new baby girl, and I do not take for granted that it is the policies by my employer that made it possible, but also the support, both literal and figurative, of my colleagues, both at my day job and on this task force. And it's clear that advancing equity is really on all of us to do. And you've heard that thus far, and you're going to see that continue as I do my brief presentation. Next slide, please. As we have all seen over these last, almost 2 years, communications and collaborations are essential to a comprehensive response to the pandemic, and government, while central to such efforts, is not sufficient. That partnership with community is critical. So the last key outcome of a comprehensive response that we will discuss is the valuing of community expertise and the utilization of that expertise to make communications more effective in our collective work to strengthen healthcare and public health. As we seek to advance recommendations to better respond to COVID-19 and better prepare us for future pandemics, we seek to ensure that communities help lead the way in identifying and implementing solutions to address their health needs, and that the wisdom, expertise, and lived experience of communities of color and other underserved populations inform public health, science, research, and our government institutions. Programs, solutions, and resources that impact people where they live, work, and play will be designed and implemented with impacted communities. The way forward is truly together, seeking to communicate evidence-based information in ways that are culturally and linguistically responsive and accessible to all people, because it is together that we will build stronger collaborations that support our collective health and well-being. The 9 refined recommendations that I will be discussing focus on 3 overarching areas of valuing community expertise and partnerships, the power of effective communications, and the need for federal leadership and coordination. Next slide, please. So first, we recommend the federal government launch a formal partnership with worker organizations, including trade unions and those representing farm workers, frontline and essential workers, immigrant and migrant workers, in order to improve equitable access to healthcare services and inclusion in pandemic and public health emergency preparedness. It's this partnership that is expected to also inform development and enforcement of necessary occupational health standards and regulations related to pandemic control. Next slide, please. In centering the power of community, we recommend the federal government further strengthen collaboration with community-based organizations and public health providers by providing robust and sustainable funding for them to build capacity, to offer technical assistance and better serve minoritized, marginalized, and medically underserved communities in public health, emergency and pandemic preparedness, as well as in response and recovery activities. With a stronger federal and community network, there will be more open communication that will allow for amplification of coordinated communications that better reach all Americans, and especially those historically underserved. Next slide, please. The strength of community-led solutions was most obvious in these last couple of years in the local work that improved access to vaccines for millions of Americans, particularly those most marginalized. Recognizing that leadership, we recommend the federal government strengthen efforts to partner with local CBOs, local community-based organizations, to collect, disseminate, and implement best practices that will expand testing and vaccination efforts to reach these historically underserved communities, and to reach them where they live, where they work, and to do so through culturally, linguistically, and economically appropriate ways. The knowledge and trust of community organizations can facilitate vaccine distribution in critical ways, creating more welcoming environments for immigrant communities, for example, or easing access for isolated or homebound populations. Next slide. In continuing to emphasize community expertise, we recommend the federal government develop guidelines for engaging communities in research. As part of this, the federal government should incentivize community engagement in research and ensure that it can be done so through culturally and linguistically responsive outreach that will encourage communities to provide substantive input to research questions, research design, results, and publications. It should also require grantees that received government funding for performing research to seek, incorporate, and report on community input in order to ensure what some of my colleagues have already discussed, the importance of accountability, and as part of the evaluation for ongoing funding. Next slide, please. So a second critical area of focus for this priority is that utilization of communications as a tool itself. So in line with this, we recommend that during any public health emergency, the federal government lead a multi-pronged education, outreach, and communications campaign, and that there be additional specific campaigns tailored to targeted communities. These campaigns should use science-based, non-political sources and partner closely with state, local, tribal, and territorial healthcare institutions community organizations, as well as other trusted entities. Strong community partnerships will enable messages to be clear, credible, consistent, and adapted to the cultural and linguistic context of marginalized populations. This is an effort that acknowledges past inequities and harms and advances efforts that seek to rectify these harms as a way of building accountability and trust in the present day. With such trust built, these communications should promote public health prevention behaviors like vaccine awareness and uptake, or testing, or contact tracing, masking, and social distancing, and will pay particular attention to institutions and organizations that serve communities who have been hardest hit by COVID-19. Next slide, please. In recognizing the lasting impacts of COVID and the information we are continuing to learn about those impacts, we recommend the federal government execute a robust communication campaign and establish an information resource center to educate the public on long COVID in ways that are culturally and linguistically appropriate and accessible to people with disabilities. Given the expertise and leadership of people living with long COVID, the resource center should provide or leverage existing forums for community members to learn more about the condition so that they may share their experiences, they can connect with equity-centered local resources, again, that are culturally, linguistically, and economically relevant. In doing so, the overall campaign will better reach minoritized, marginalized, and medically underserved communities, as well as the healthcare workers that serve them. Next slide, please. COVID-19 has fundamentally challenged the delivery of healthcare services across our country and across the world. And it's forced many difficult choices on health professionals and has laid bare the many pre-existing challenges that we knew were part of our health and public health sectors. This has been stated over and over again by our task force members today. Recognizing this, we recommend the federal government convene a multidisciplinary panel, including clinicians, civil rights attorneys, ethicists, health equity experts, and community members to assess and update the crisis standards of care work produced by the National Academy of Science and Medicine. These crisis standards of care occur when the degree of resource shortage requires decisions that place a patient or provider at risk of a poor outcome. It's these standards that can help ensure our systems are better prepared in the future. And we recommend that these standards, once they're finalized, be widely disseminated, that the benefits of such standards be explained, and that adherence to them be incentivized through accreditation and reimbursement requirements. Next slide, please. So finally, these last couple of recommendations really does focus on the leadership of our federal government in coordinating the response to the pandemic that we are in now, as well as future pandemics. So this next recommendation focuses on the opportunity to leverage federal authorities for public health emergency, pandemic, and disaster response, and establish a definitive public health federal authority for coordinating and leading COVID-19 and future pandemic responses. The authority will serve as a central point and coordinate, fund, research, and communicate with a variety of stakeholders in order to leverage their scientific and technical expertise. The idea being that it will be stakeholders from science, from research, from healthcare, from communications, from public health emergency and disaster response, but also with expertise in centering equity in order to ensure that the work we do moving forward, that the work we do to respond to the pandemic are centering equity in and of themselves and are reaching those hardest hit. Next slide, please. And finally, in order to ensure we are taking away valuable lessons learned and a rigorous evaluation of our collective response to COVID-19, we recommend the federal government offer the opportunity for a comprehensive review by an independent blue ribbon panel of the government's response to COVID-19 and the whole of government's response. A thorough analysis includes a review of the performance of public authorities at the federal, state, and local levels, given the complexity of the responsibility of such the response. The panel would make additional recommendations to increase preparedness using its analysis, building on this task force's recommendations, as well as seeking input from a variety of diverse non-governmental stakeholders. Next slide. So before I hand it over to our chair, I just want to close by saying we believe that these recommendations make clear that the federal government has a unique communications and collaboration leadership role, but that it is a role that is strengthened by its commitment to community expertise and community-led solutions. So with that, I'm going to hand it over to our chair for discussion.
Thank you so much, Ms. Alvarez. And again, a tremendous presentation, reflects so much incredible work, spot on. I do want to take just a moment of personal privilege to say deeply grateful, as I know we all are, that you will take time from your parental leave to join us and be with us and to be still so deeply engaged and leading us in this work. So a personal thank you on behalf of the task force for your steadfast commitment and leadership in this space. Once again, no small feat, but tackled heroically. So thank you very much for that. I appreciate your leadership as the subcommittee chair, and of course, bringing all the work together now under the umbrella of that suggested outcome. This slate of recommendations is now open for discussion if any of the task force members would like to contribute. Dr. Putnam, please, the floor is yours.
Thank you, Madam Chair. I appreciate the work that the whole task force put in this. Again, I'll just reiterate the amount of detail and things. I really wanted to focus on one, and that's the definitive pandemic authority. I think one thing that I really want to emphasize is that this needs to be a diverse group. It really needs to have expertise. I mean, with regard to vaccinations, we need people that are experts in logistics. With regard to expansion of inpatient capabilities of hospitals, we need people that understand everything involved in that, in addition to virologists and experts in the medical field. So I think that is really an important point. The other thing is I truly believe if this is an apolitical process, that it is really led by science and people who understand how best to deliver care in the nation and respond to a pandemic, will grow that credibility. And I think that needs to be developed now in an agrarian way, realizing that it's going to take years, if not decades, for that group to gain credibility. I think that's one thing that we need to work at. We need to work at hard and be continual and purposeful about. So I appreciate that recommendation being in there. And I just know that that one will not happen overnight. But if that group does their work well, it'll be something that will gain the trust of the American people. So thank you.
Thank you so much, Dr. Putnam. Dr. Martinez, please.
Thank you, Madam Chair. I want to thank Myra for being an excellent chair for this committee, and then also Andy for pinch hitting while she was on leave. So it was a dynamic duo. To my colleagues and the rest of the committee for weighing in on these important issues when it comes to communications and collaboration. I want to highlight the working with communities, collaborating with communities when it comes to research. I think that's a huge potential opportunity that there's been a little bit movement into that, but I just want to state that we need to be looking at from a research standpoint that our communities, the cohorts we want to learn more from should be seen as subject matter experts in their domain as a community. And so we want to work with communities, I think of them as citizen scientists, help them to acquire those skills, have, community-based institutional review boards as an example. Imagine what we can do, as well as including them from pretty much the problem idea brainstorming stage through then the research that needs to be happening to the translation stage, and then even the implementation and coming up with intervention stage. Why shouldn't our communities be part of the process? I think we could enrich and have so much more robust type of research and help us, in fact, to ensure that we're not leaving anyone out, but are achieving equity from a research standpoint. There's already community-based participatory research models out there, but I think we can expand and enhance on that. And I'll end with this for our researchers, our clinicians, and our health administrators, that there's already a framework out there. And the national standards for culturally and linguistically appropriate services in health and healthcare has been around for quite a while, and in fact has been modified a few years ago, known as the national class standards. Let's ensure they're being implemented across the board. It's a framework that'll help us to improve healthcare quality and advance health equity. Thank you, Madam Chair.
Thank you so much, Dr. Martinez. Really appreciate it. Mr. Toronto, please.
Thank you, Madam Chair. I just want to take the time first to thank Ms. Alvarez and Mr. Imperato and Dr. Martinez for their work. And it was really great to work with all three of you on these recommendations with communications, collaborations, and to the rest of the task force for collaborating with us on finalizing these recommendations for the final report. As we know, the key to ending this pandemic is to get vaccinated. That's something that the federal government has been pushing, state governments have been pushing, local governments. Obviously, the more people that get vaccinated in this country, the more of a chance we reach a level of herd immunity. But however, there's been long debates on whether we're facing hesitancy issues or access issues when it comes to populations that are not yet vaccinated. And sometimes many fail to realize that being hesitant or reluctant may be a result of lacking the information, lacking the access to information and knowledge needed to make the important decision to get vaccinated. So that's why it's vital that the federal government partners with state, municipal, tribal, and territorial governments to reach out to populations in hard to reach areas. Partnering with community centers, nonprofits, and universities can also make a big difference, especially when trying to reach younger audiences. As a member of Generation Z, I've seen firsthand the issue of vaccine reluctance among young people, and this can be solved with a continued strong, coordinated campaign that the federal government has carried out of reliable information, which is why this task force has recommended that virtual or televised forums and town halls and efficient communication should be held to specifically target young people and other populations that have been hard to reach. This pandemic has shown us how important it is to maintain a cohesive and apolitical informational campaign during public health emergencies, especially at a time where political polarization is high. I'm proud of the work that this task force has completed on the issue of communicating effectively with the American people. And if our recommendations are acted on, I have no doubt that we will truly witness a more equitable response and recovery for the current and future pandemics. Thank you.
Thank you, Mr. Toronto. Always appreciate everything you say and bringing that Gen Z perspective every time. Thank you. Mr. Imperato, please.
Yeah, thank you. I just want to first commend Myra on her leadership of our subcommittee. And I'm grateful, and I wanted to lift up the recommendation related to crisis standards of care. In California, in April of last year, our State Department of Public Health came out with crisis standards of care guidelines that we felt were discriminatory against people with disabilities and older Californians. And when civil rights attorneys communicated with the state, to its credit, the state changed their guidelines in response to our concerns. But I just want to lift up the importance of having the perspective of people who understand disabilities, civil rights, and the rights of elders as part of the development of crisis standards of care. And I also think there's a research piece, and I see Dr. Khaldoon has her hand up. We don't really know all the different ways that healthcare rationing has gone on during this pandemic. If you look at the state hospitals in California, for example, where people with mental health disabilities live, we had 76 people die from COVID in the state hospitals. And this kind of goes to what Homer Venters was bringing up about making sure that people get the standard of care in these carceral settings and other congregate settings. So I encourage us, as we think about crisis standards of care, to try to get an analysis of who died because of healthcare rationing during this pandemic, including people that couldn't get non-COVID related healthcare because all of our healthcare resources were being allocated towards COVID. So I just encourage us to think about the rationing issue more broadly.
Yes, thank you so much, Mr. Imperato. Agreed. Dr. Khaldoon, please.
Yes, thank you, Madam Chair, and thank you to Ms. Alvarez and Mr. Imperato for your leadership. I really find these recommendations just really bold and necessary, but I wanted to also elevate the importance of engaging with the community, but not waiting until a crisis happens. I think especially at the local and state level, it's imperative that these relationships with community-based organizations, with schools, with businesses, all of those things really should have already been established before this pandemic. And if they were already there, we would have seen less, I think, when it came to inequities in outcomes. I think also it's important when we speak about crisis standards of care and pandemic preparedness, we have to bring other entities besides the usual public health departments, emergency management, healthcare systems to the table when we're doing those tabletop exercises and doing all of our planning and preparedness. All of our states and municipalities, they had preparedness plans. They did tabletop exercises, but quite frankly, the most important people from the community were missing from those planning efforts. And I think it really showed in our implementation and in our response. So thank you. Thank you for the opportunity.
No, thank you. Very much nodding. Much appreciated. Mr. Watts, please.
I want to thank Dr. Calhoun for that statement and really lift up the very final recommendation of conducting a COVID-19 after action review, which emphasizes that the input includes diverse non-governmental stakeholders giving that input. And I think that is so important. I think we've done so many things on the fly. The word unprecedented is used over and over in describing the pandemic and our response to it on many levels. And I think it's so important as part of our charge to the task force that we are not only responding in real time, but we're helping to prepare for the next pandemic. So I am so glad that we're saying there should be a thorough review of many things, what worked, what didn't work, so that we can shorten the learning curve for the next time. And I believe that one of the things that we're most focused on right now will be part of that study, and that is the effects of mandates. How does it promote equity? Where does it not promote equity? What can we do to make sure that it is tailored in the future? When should it be deployed? I think will be extremely important for an equitable response in the future.
Thank you so much, Mr. Watts. I think you have the last comment on that slate of recommendations from the task force. So very grateful for that. Let me pause again just to thank you, Ms. Alvarez, one more time for the leadership. And of course, as many have acknowledged, Mr. Imperato stepping in to assist with that subcommittee, all much appreciated. And I thank you across the board. You know, we have now presented and shared the full slate of recommendations for consideration, as well as proposed priorities and suggested outcomes. It's important to just take a moment and acknowledge that amount of work that has come out of this group and this body. It's tremendous. And has, as many have noted, deep potential for transformation and to set us on a course to get to that new and better normal. It is currently, looks like 3 after the hour. We will take a brief break, return for public comment. Because of this hard work, I think we can go until 15 after. So return 15 after the hour, and then we will welcome public comment. Thank you, everybody. Everybody looks refreshed. Welcome back. Good to see you. At this time, we will invite public comment. I will turn it over to you, Dr. Wendt, please.
Thank you, Madam Chair. So as with all federal advisory committees, this is an opportunity for the task force to receive comments from the members of the public. So we received 4 requests to deliver comments. I will announce the speaker names and affiliation. When you are called, you can go ahead and unmute yourself. If you are on the phone, press *6 to unmute. Please keep your remarks to 3 minutes. First, we will hear from Ms. Riva Singh from the American Academy of Physical Medicine and Rehabilitation. Ms. Singh, please proceed.
Good afternoon. My name is Riva Singh. I'm the Director of Advocacy and Government Affairs with the American Academy of Physical Medicine and Rehabilitation. I want to start off with thanking you, Dr. Nunez-Smith, and the task force for all of your thoughtful work and for your recommendations. We are so grateful for your attention to this massive issue of health equity and to long COVID. Earlier this year, AAP-MNR put out a call to action to create a comprehensive national plan to meet and defeat the long COVID crisis. This crisis is only getting larger as time goes on. We appreciate what has been done so far and are particularly thankful for the large collection of resources and supports that the administration released on July 26th, clarifying that long COVID may rise to the level of a disability. But there is more work to be done. AAP-MNR believes that the most effective way to address the long COVID crisis efficiently and comprehensively is through the designation of a coordinated interagency group at the federal level that works together on a plan to address the myriad of issues that long COVID presents. There's healthcare infrastructure, equitable access to care, clinical research, but beyond healthcare, there's also the impact on the economy, accessible education and workplace accommodations, disability evaluations, and other issues that may arise from an estimated 12 million Americans and counting suffering from long COVID. We believe that this coordinated body and comprehensive plan is imperative to ensure that there are no gaps in access to care, benefits, or resources. And we believe that this recommendation is aligned with recommendations coming from this task force. AAP-MNR's multidisciplinary collaborative of physician specialists, researchers, and patients is working to put out consensus guidance statements addressing the most commonly appearing symptoms of long COVID. Our fatigue consensus guidance statement was recently released, but additional statements are in the works, including statements on cognitive impairment, breathing discomfort, cardiac and autonomic issues, neuropsychology, and pediatrics. This collaborative is a wealth of knowledge, not only clinically, but also to better understand access to care barriers and healthcare infrastructure concerns. We hope the Health Equity Task Force will recommend AAP-MNR and its collaborative be considered a resource on long COVID and included in any stakeholder advisory group. Again, thank you so much for all of your hard work and for the opportunity to speak today.
Thank you, Ms. Singh. Next, we'll hear from Ms. Terry Wilder from the ME Action New York. Ms. Wilder, please go ahead.
I am not able to open my video. Somebody could undo that for me. Hi, I think somebody has locked my video, so.
We can hear you all right, so please go ahead and talk and then we'll try to figure it out. Thanks.
All right. So thank you for allowing me to speak with you today. My name is Terry Wilder, and I will be reading my remarks as I have brain fog. I realize that you've been working on your recommendations for some time, and I'd like to highlight a few recommendations that myself and others find important. In March of 2016, I was diagnosed with myalgic encephalomyelitis, or ME. This disease is a complex chronic disease. It's a neurological disease according to the World Health Organization. It cannot be treated or cured by graded exercise therapy and is not a psychiatric illness. It is often referred to as chronic fatigue syndrome, which I find to be highly stigmatizing and limiting to what my reality is, and encourage you to avoid that label. The reason why I'm sharing this is because the ME community saw long COVID coming from a mile away. We predicted that long COVID would happen to a percent of people who got COVID. Why? Because many of us have had the same experience. ME is a common chronic consequence of viruses. There are estimated 1 to 2.5 million in the United States with ME. The number is growing because of long COVID. In August of 2021, the New England Journal of Medicine published a perspective article titled Confronting Our Next National Health Disaster, Long Haul COVID. In the article, the authors state that factoring in new infections of unvaccinated people, we can conservatively expect more than 15 million cases of long COVID resulting from this pandemic. And though the data are still emerging, the average age of patients with long COVID is about 40. Given these demographics, long COVID is likely to cast a long shadow on our healthcare system and economic recovery. This is not a new phenomenon. Like I said, the ME community saw it coming from a mile away. If the government had invested resources, research, healthcare, and social services for people with ME 40 years ago, we wouldn't be here today with long COVID. The relationship of long COVID to ME has been discussed by the CDC, NIH, and other groups. In July of 2021, I asked Dr. Tony Fauci his thoughts about this connection during a press conference I attended. And in his response, he stated that long COVID is highly suggestive of ME. I should tell you that the ME community has never had equitable access to high quality health care. It didn't exist in our world, and it won't exist for people with long COVID without the right resources. I believe that healthcare is a right, so my recommendation is to put serious funding into medical education around ME and long COVID and unconscious bias. These medical education interventions should include webinars, conferences, and preceptorships, Project Echo, clinical diagnostic tools, as well as resources to get real experts to publish articles in medical journals that give the message that these are real diseases and that it is malpractice to deliver health care from a place that they are not. My second recommendation is to demand that the NIH, and Dr. Francis Collins in particular, make ME and long COVID research a priority, and in particular fund ME research at a level that is proportional to the disease burden. Because according to their numbers, my life in New York National Institute of Health research dollars is somewhere around $7. I support any recommendation that ensures meaningful participation by people with lived experience. That is not happening at all levels of government. Health and Human Services must bring back the Chronic Fatigue Syndrome Advisory Committee that was disbanded under the Trump administration. I'm begging you to add this to your recommendations. Under the last administration, we were told that we had met our goals in this committee and that there was no need for us to meet anymore. Clearly, that was wrong. It must be brought back with a different name under a new charter with bold leadership and resources and with representatives from all key stakeholder groups, including government. I'm available to help, and I hope that Dr. Rachel Levine will help this as well. We need data. We have no idea how many people have ME in this country or long COVID. In the case of ME, it has been over 40 years. We need a case definition so that we can be counted. The CDC needs to get on this immediately. We must confront systemic bias, including sexism and racism, in the long COVID and ME response. The majority of people with ME are women, so sexism is killing us. And for people of color, and specifically Black people, they are consistently underdiagnosed or not diagnosed at all. Racism and unconscious bias is killing them. This is criminal. We must leverage existing post-viral disease knowledge and infrastructure, basically reach out to our community and pick our brain. We are familiar with this. We must expedite public-private partnerships. Pharma is never interested in us. Why? Because nobody ever takes our disease seriously. There would be interest in treatment discovery if the message was delivered that this is a public health crisis. And finally, we must deliver evidence-based treatments to people with these diseases immediately. We can't wait any longer. Some of us have been waiting for decades. And one final bonus recommendation. Please be sure to have an implementation plan in place for these recommendations. As a person who's served on millions of committees and task force, nothing is as frustrating as working hard to find out nothing is implemented and no one was monitoring the workflow. Make sure that happens. So in conclusion, I'm begging you to use your influence to save our lives. As you are looking over your final recommendations and making your last edits, please connect the dots and save two communities, the long COVID community and the ME community. Vaccines alone will not end this epidemic. People are sick now and have a life of illness ahead of them. When you are writing about long COVID, include ME in the recommendations and healthcare research communication plans. It is critical to those of us who've been suffering for 40 years and will be to those who've been suffering for the past 19 months. And please don't forget my name, Terry Wilder.
Thank you, Ms. Wilder. Next, we'll have Dr. Harold Smith from the University of Pennsylvania. Dr. Smith.
Hi, my name is Harold Schmidt. I'm an assistant professor of medical ethics and health policy at the University of Pennsylvania. I'd like to congratulate the chair, the task force members, and especially also the staff for this truly Herculean effort that could hardly be more timely or important. My comments have to do with a simple but deep issue that is directly connected to the task force charge under Goal 6 of the National COVID Strategy, namely recommendations on federal guidance for crisis standard of care. These comments also underline the urgency of updating existing guidelines and governance and understanding how rationing happened as noted in the previous session just now. The issue is this: 3 states that have activated crisis standard of care in recent weeks are basing their rules on now outdated algorithms that mean Black patients face far worse chances at receiving a ventilator compared to white patients. Based on joint work with my colleagues Dorothy Roberts and Namaka Eneanya, already published in the Journal of Medical Ethics as well as forthcoming there, I'd like to suggest that this injustice should not stand. First, and most importantly, right now, we knowingly and erroneously disadvantage Black people in ventilator access. Second, we need to understand how and why this happened there and likely elsewhere. And third, we need to identify clear measures that avoid repeats in this pandemic as well as future ones. Idaho, Montana, and Alaska all recently activated crisis standard of care, and all 3 states draw centrally on the SOFA score, a measure to predict the likelihood of ICU survival. The first major problem is that SOFA is not fit for purpose. To be clear, this is not my personal assessment, but the conclusion of a joint expert panel by the Task Force of Mass Critical Care and the American College of Chest Physicians, who state that the SOFA score is unlikely to predict clinical care outcomes with sufficient accuracy and is not a useful basis for triage decisions. The group published their report in spring 2020, and a discussion paper on COVID equity lessons learned that was published about 4 weeks ago by the National Academy of Medicine also advises against SOFA. And yet, these 3 mentioned states use SOFA right now. But SOFA is not only bad science, it's also inequitable. 4 robust studies that I will share separately with data on more than 100,000 patients now all confirm that both SOFA alone, as well as when embedded in triage guidance, such as used by Idaho and Montana, assigns disproportionate numbers of Black patients lower priority tiers and erroneously excludes them from the highest prioritization. Note that the authors of the model guidance that these, as well as many other states adopted, published a revised version in December 2020, in which they acknowledged, quote, important equity problems, unquote, of guidance, including their own, and offered a number of revisions, including dropping the SOFA score. Unfortunately, 10 months after publication, policymakers in Idaho and Montana seem unaware that both states incorporate an earlier and more inequitable version of the model guidance. None of the 3 mentioned states, nor any other state or hospital, should ration ventilators on outdated and more inequitable guidance. 2 things could help to change that. First, appropriate units within HHS could contact all state health departments to share the evidence on the harmful consequence of using the SOFA score and discourage use. And second, going forward, a systematic inventory of state-level and other triage protocols should be created and maintained within HHS. Whether public or non-public, even a non-public version would create incentives for states and hospitals to establish triage protocols and keep them up to date. For now, thank you again for everything you've accomplished this year. I'm really just in awe.
Thank you, Dr. Smith. Next, we'll have Ms. Jennifer Stoll from OGIN. Please proceed.
Hello there, Chair Dr. Nunez-Smith, members of the COVID-19 Equity Task Force. Thank you for the opportunity to comment. For the record, I'm Jennifer Stoll, Executive Vice President of Government Relations for OCHIN. OCHIN is a national nonprofit health technology and research organization with over 2 decades of experience providing leading-edge technology, data analytics, and support services for over 1,000 community healthcare sites, reaching nearly 6 million patients, 21,000 providers in underserved communities, predominantly low-income, uninsured, medically complex, and those with facing significant structural inequalities. OCHIN members and patients know firsthand the negative, disparate impacts of COVID-19 and structural inequality. And during the pandemic, OCHIN has been sharing our data and learnings to policymakers, including the administration, of what we've been seeing about health inequities during the pandemic for the last 2 years. OCHIN has submitted formal comments consistent with the incredible findings of this committee, and we strongly support and admire the recommendations and the work of this task force. So it is with deep respect that we would like to highlight a couple of key items as it relates to data and the ability to capture data for the purpose of this work. Number one, it is very, very important, and data will only be aspirational without the investments to modernize health technology and the technical support for providers, public health agencies, justice organizations, and community service organizations. This was a foundational problem during the pandemic. Not having good quality systems to capture the data is a key problem still. The second thing is workforce. The expanding workforce in health technology and making this a key priority is very, very important. Our workforce in health technology is not reflective of those communities we serve, and we stand ready to support you in this effort. And finally, permanent access to telehealth and virtual modalities through the extension of current public health emergencies is foundational in being able to continue to reach patients, especially those with social determinants of health and other challenges facing our communities. So OCHIN stands ready to be a resource to this committee and to HHS as you further and implement these recommendations. We thank you and admire so much all of the work that each and every one of you have done. And I'm happy to stand ready to support you. Thank you.
Thank you, Ms. Stahl. So this concludes the public comment. Back to you, Madam Chair.
Thank you so much, Dr. Wendt. Let me also add my thanks there for the public comment. We will turn now, task force members, to the vote. Following up on our earlier presentations, we will vote sequentially 3 times. We will first take up the slate of final recommendations in their totality as one vote. And then we will turn to vote on the slate of suggested outcomes. And then last we'll vote and the proposed priorities. Okay. So first for consideration, the complete slate of task force recommendations. Do I have a motion, please, to advance the slate?
So moved.
In unison. Thank you. Mr. Imperato, move the motion. Dr. Martinez, is that a second?
It's a second.
Thank you so much. Any additional discussion? Seeing none, we will proceed. I call now, if you to signify agreement with moving the motion forward, yeas, please, by show of hand. Thank you. Hold for one moment, please, to allow for the count. Thank you so much. Any names? Any abstentions? All right, I vote yes. Thank you so much. Motion carries. All right, we will turn now to take up the consideration of the suggested outcomes, which there were 4. Do I have a motion to advance the suggested outcomes?
So moved.
Thank you. Thank you, Dr. Putnam, for the second. Any additional discussion? All right, seeing none, yeas, please. Signify by show of hands. Hold for one moment, please. Many thanks. Any nays? Any abstentions? I vote yes. Thank you so much. The motion carries. We will finally take up the proposed priorities, which there were 5. Do I have a motion to advance?
So moved.
Thank you, Dr. Hildreth, for the move, and Mr. Imperato, the second. Thank you. Any additional discussion? All right, seeing none, yeas, please. Thank you. Hold for one moment. Thank you. Any nays? Abstentions? All right, I vote yes. Motion carries. Nice job, team. We've advanced now the full final slate of recommendations, as well as the outcomes and priorities that will be included in the final report. As we get ready to close this, our 7th meeting, I just want to take a moment and thank everyone again for participating along with us. An extra special thanks, as always, of course, as I look around the screen, to each one of you, each task force member, generating continuously those thoughtful recommendations for our deliberation and consideration. Thanks as well to the CDC Foundation, to our executive director, to our DFO, the entire federal staff team. As we are all acutely aware, it takes many, many people to support this work. There's deep gratitude for that. Thank you as well, and also to our ASL interpreters. So the focus quite often can be on medical solutions. Those are important. We know in addition to medical solutions, an effective pandemic response is going to be heavily reliant on people's trust, right, in public health, in research, and that's going to be grounded in meaningful and sustained community engagement. Misinformation, messaging that's conflicted, inflammatory, unhelpful rhetoric, the politicization of science, that has undermined the pillars of our effective response. So we're moving boldly towards this new post-pandemic reality, a reality that will put science, reliable communication, community, health, racial, ethnic, social equity, all at the forefront of our pandemic response. So next month, we will meet to present and discuss the COVID-19 Health Equity Task Force final report. The date and the time of our meeting will be provided in the meeting notice that's going to be published in the Federal Register. The notice will also be posted on the task force website. If you're looking, you can also find the recordings and minutes of past task force meetings there at the website as well. So with that, thank you again, everyone, for joining. Much appreciated, everybody. Please be safe. And with that, we are adjourned.